Can you hear me correctly? Yes. Yeah, that will do. Yeah, now you should be hearing me.
Yeah, now it's okay.
Yeah?
Yeah.
Okay.
You can. Okay. How I can bring. A ja przejesz obecnie. Onda ajde kad već šalješ ovaj iz nekog razloga. Hoću switchat, moramo ići s ovim. Onda do nas. Nas. I prenos se radi. Ovo je kao. Ovo je kao. I šta? Moram ići kod registration, već ću to zabiti. Mogu ja još 10 minuta. Stigneš. Stignem. Uglavnom otvrđuje sve i svašta nešto i malo smanjuje čini se da je gain.
So I was thinking, Heinz is because I might need to be with the videos during the workshops. The question is whether I don't know, Lydia. I think Birta told me that Lydia could be in the replace me in the workshop as taking
I
notes.
imagine my life.
Yeah, do you think she can?
Do your best
Okay.
and receive applause for taking action.
So you are
I
controlling
will
this
not
from
let
there.
pain
Okay.
win.
I don't know, but the video or was me who it was me who activated. Yeah. Okay. Okay, I will close it then. Okay.
So, are you gonna be presenting?
No, I will not present. No. Why it doesn't? It doesn't. Why?
Did you properly close? Maybe you took it out too early?
No. I just any of the files. Any of the files. No. Wait. Oh.
This one is louder than the desk mic. Eh. Yeah, I'm gonna test the table and the desk mics. Test 1 2 test 1 test. Test 1 2 test
Copy.
1 2.
So, good morning, ladies and gentlemen. It's a particular pleasure for me to welcome you here at this very important conference, which has the title, Reducing the Burden of Chronic Diseases in the Workplace. My name is Gerd Burmester, and I'm the current president of the European League Against Rheumatism, to you all known as EULAR. In my second life, I'm a rheumatologist and clinical immunologist in the city of Berlin. So that's where I see many patients, and I'm quite aware of the problems that the patients have. And part of this will be covered here in our conference. And let's just have a look what the conference will encompass. It's the World Arthritis Day, which is very important because it's all across the world. We deal with arthritis, rheumatic and musculoskeletal diseases. And while we speak here, I guess many preparations in many countries are taking place to prepare the World Arthritis Day, for instance, in Germany, in Portugal, and in many other places in the world. So this is a very, very important event, and I've contributed frequently to the World Arthritis Day, for instance, in Germany. So the annual conference has been taking place since 2010. I had the pleasure to attend several of them, and they usually are of remarkable quality. They bring together rheumatic and musculoskeletal diseases and the community dealing with this, and policymakers and stakeholders. So it's a community of those being involved and conflicted with the disease, and the stakeholders who let's say, are doing patient care, who are doctors, physicians, epidemiologists, and many other aspects. And of course, policymakers are very important as well. And we would like to focus on the relevant policy developments here. So what is the focus of our World Arthritis Day today? It is health and safety at work. And I know what I'm speaking about because 23 years ago, I went from West Germany into East Germany to work at the Charité University Hospital. Reunification. East Germany had then quite a few economic problems, and when I took care of patients, and at that time we diagnosed a disease, let's say like ankylosing spondylitis or severe rheumatoid arthritis, it immediately threatened the workplace of the individual who was affected by the disease. And so luckily, more and better therapies have arisen in many areas of rheumatology, so that now we also have the medical tools, but also other tools to deal with these diseases and to combat them. And this is a very nice opportunity for all of us now to address all of these issues in a very positive way. And I think that is very important because the rheumatologists always like to complain, and rightly so, because we are not enough, we are neglected diseases and so on. But I think that is usually doesn't help us. It helps us to raise optimism, because we can treat the diseases now much better. We know about the diseases, and of course we have managed, along with the politicians, the public affairs group of EULAR, to raise awareness about the diseases. And so we will focus on these. And we all know that rheumatic and musculoskeletal diseases are the main work-related health problem. So whenever I read the statistics of, for instance, the German health insurance companies, RMDs rank number 1, and interestingly, number 2 are ranking the psychological disorders that are also combined with the workforce, with the constant email messages that we receive and so on. We're sometimes overburdened by this, but still, and I'm sure it will remain like this for a very long time, RMDs, rheumatic and musculoskeletal diseases, are the main cause for staying away from the workforce, for being going into the pensions and so on. So this is really very, very important. So therefore, we need to develop adequate working conditions to reduce the burden of RMDs in the workplace. And we must realize, and we discussed this already yesterday in the preparation of this conference, this is a good investment. We have to tell everyone involved, this is not just a waste of money and additional money, but it's an excellent investment, because this way we keep gifted people in the workforce so that they can perform at their best. So the conference goal would also be, of course, to develop policy recommendations. And now we have two important items: prevention and retention. So prevention of RMDs in the workplace apparently is, of course, very, very important to prevent, for instance, all the problems surrounding computer workplaces and looking at the desktop and looking at the screens all day long, so that you get all kinds of problems in your spine and other areas, of course, and also if you're working in the construction business, and others, if you're working as a nurse, you have to lift very heavy patients all day long. So these are very important issues where we need, of course, prevention. But also, once a person is afflicted with a rheumatic disease, like as I mentioned in the beginning, it is also very important to retain these, and usually very energetic and gifted and highly motivated members of our society in the workplace. So this is very important. And therefore, we appreciate very much the EU OSHA campaign on healthy workplaces for all ages, and EULAR has signed up to be involved heavily in this particular campaign. So let's just talk about a few things about the conference. So first we will start with, and I can promise to you, some highly informative plenary contributions. And then, of course, the beauty of the World Arthritis Day in our conference are always the workshops. We will have 3 workshops: prevention of RMDs, access to occupational therapies, and retention of people with RMDs in the workplace, so that we can come up with some concrete proposals that we will then be discussing in the reports right after lunch. Then we will have a panel debate, and finally we'll have a closing session with some important items that arose from our conference. So we also have a live streaming of the plenary sessions, which is ongoing. So I say hello to all those sitting at the computers outside, probably from Portugal to Russia, from Sicily to Norway. So hello and welcome to this conference. And we can also share news and views on Twitter. It's hashtag EULAR Brussels 2016, and we welcome any Twitter remarks as well. And we would like now to start to set the scene a little bit with I think it's a very nice video, and that shows us what RMDs really mean and how we can combat them. And so I would like to show this video here.
I imagine my life is a theatre play, and I'm the lead role. Nobody can ever replace you. You must perform your best and receive applause for taking action. I will not let pain win.
I visited the specialized gym. I discovered how to enjoy physical activity and started on a particular diet. I could do many things by myself to improve my quality of life. I realized that my future was in my hands.
It's very difficult for a child to cope with a chronic illness. But it didn't stop me from studying at the university and become a kindergarten teacher. Look at life from a different point of view and grab every chance. Everyone is different and unique.
Pain and fatigue ensured I didn't have capacity to do much-loved hobbies. Singing gives me renewed energy and positivity. Research into innovative new treatments has also enabled me to get back to a hobby I am passionate about. head, I'm not sick. In my heart, I'm unstoppable. I started blogging about my invisible illness to create awareness about living with rheumatic and musculoskeletal diseases. I'm taking back control of my life, and it feels great.
So I think that was quite an impressive video and really nicely sets the scene to today's subjects and themes. And I would also like to allude a little bit because EULAR, and I realized this for the first time in the history of EULAR, which will be 70 years long next year, we will launch a campaign which is called Don't Delay, Connect Today. We're just in the midst of the preparations, and I think it nicely pertains to the subject we are dealing today, because you need to act quickly, have connections early on in order to stay on the workforce and to also to prevent a chronification of these diseases. And I promise you we will have nice videos like this also for your help in the various countries. So this also gives me the opportunity now to thank everyone involved. We will name them, but I think it is everyone giving a lecture today and being involved in the discussions and workshops. They all have a very, very busy life. And so it's not so easy for many of the stakeholders, the politicians and others to come here, but I think they really have devoted their time to this very important subject, and I would like to thank all of them. I would like to thank the Brussels EULAR office, Søren and Federico, and of course Neil Betteridge, who is instrumental, the sort of the mastermind behind many of the items we're discussing today. So that gives me the opportunity to present to you the welcome note of Marianne Thyssen, who unfortunately cannot be with us today, but she is the Commissioner for Employment and Social Affairs, but we can have her here actually by using a video as well. So we'll have a video message.
President Boermeester, distinguished participants, Europe's greatest asset is its people. We must work together at all levels to enable every individual to fulfill their potential and contribute as fully as possible to both society and the labor market. People with health problems deserve protection and support so that they can continue an active life and work. EULAR's contribution to improving the situation of people suffering from rheumatic and musculoskeletal diseases is vital, and for my part, I sincerely thank you and congratulate you on your work. Our European Occupational Safety and Health, or OSH legislation, provides a strong basis for mitigating the risks of work-related musculoskeletal disorders. But more needs to be done so that the existing obligations are effectively applied in workplaces. Indeed, the OSH Strategic Framework 2014-2020 has set the prevention of work-related diseases as a key priority. I am truly glad to see concrete actions being implemented already. These include an exchange of good practice on ways to improve working conditions and promote reintegration measures, and realization of many European campaigns, of which EULAR is an official partner. Today's conference fits well with the ongoing consultation on the European Pillar of Social Rights. In this debate, we are considering the best ways to keep pace with change in our societies and the new world of work. Rights related to health and safety at work have always been a cornerstone of European social policy and are, of course, centered to our discussions. I wish you every success for your conference.
So I would like to thank Marianne Thyssen very much for her welcoming remark. And now we will it's a particular pleasure to introduce to you Dr. Roberta Metsola. She is a member of the European Parliament, and she's also the head of the interest group dealing with RMDs. And so it's a particular pleasure to have you here. She's original from the country of Malta. I already said many compliments about Malta. It's a very nice country. Everyone must have been once in the life to La Valletta and to that beautiful island. So thank you very much for being with us today. Thank you very much for serving as the head of the interest group. This is highly appreciated, of course, by EULAR, and we are very thankful that you can give us a welcome remark here as well.
Thank you very much, Professor Burmester. Thank you very much for being here today on this, let's say, momentous commemoration or organization of such an important day. Let me also thank EULAR for their organization and for working on these initiatives that affect so many people across our continent. This is the reason why, as soon as I got re-elected in 2014, I decided that if I had to choose one particular area that I wanted to work on, which goes beyond what I spend most of my time on within the committees, the Civil Liberties and the Internal Market Committee, was precisely this area. And this is because, first of all, and here I see my compatriots in the audience who are extremely supportive of my activity in this area, but also because there isn't so much awareness. I came into this parliament not knowing enough about RMDs. I came to this parliament only having heard of certain statistics that were not reflective of reality, and I want to do more, knowing the limitations of the European Union, but also understanding the importance of the exchange of best practices and also the exchange of experiences across our continent. Health and social or employment policies have been too often, in my opinion, politically siloed, with little interaction between their communities and stakeholders. And in fact, that's why I'm really happy that EULAR is bringing both thematic spheres together in this conference. The European Parliament is the representation of the European citizen in the EU arena. It is our role now to make sure that the political and legislative action deliver on societal needs. There is too much criticism at the moment that people feel that members of the European Parliament and anybody who works in Brussels is too detached from what happens in the member states and the capital cities. It is our responsibility, mine included, to make sure that whatever I do here is reflected and heard and felt back home in order for us to justify ultimately our existence. I am the chair of, as I said, of the European Parliament's interest group on rheumatic and musculoskeletal diseases. Now, this is a term, as you know, used to describe over 200 individual diseases, including arthritis and other joint diseases. But, as I've said before, to those who are actually affected by RMDs, it is much more personal. The physical, mental and psychological struggles faced by those with such diseases and their caregivers can be debilitating and isolating. Such diseases affect more individuals, this is something I didn't know before, than any other single disease group. And a third of all people of all ages are affected at some point during their lifetime, and women are affected more than men. Now, such diseases, as we heard in the video significantly affect not only the person's quality of life, but also the quality of life of their loved ones, and they can be debilitating to the point of loss of mobility and independence, forcing reliance on caregivers and family members. And this is an issue that the European Union cannot ignore. Now, the majority of health policy, as you all know, is member state competence, but this doesn't mean we should do nothing. There is a lot that can be done, much more than has been done so far, that would have the aim of contributing to the benefit of those persons, our compatriots, EU citizens and residents who are affected. We can encourage member states to coordinate health policy. We can discuss innovative ways to assist the elderly and the aging population. We can increase awareness within the Parliament about these diseases and the people they affect. And ultimately, of course, we can motivate agenda setting in other policy areas that might not necessarily look like they are related to RMDs, but ultimately we realize that our role in affecting that policy would be crucial. We must also work harder on the better prevention of musculoskeletal diseases at the workplace. We know that these diseases are one of the main occupational diseases in Europe, and we know that they are one of the greatest causes of disability, accounting for nearly 30% of persons with a disability, and they account also for the largest amount and share of working days lost. Millions of Europeans are annually affected by temporary incapacity caused by work-related musculoskeletal conditions. And this is something that I bring up when I visit places of work where there is a higher incidence of persons suffering from such diseases that are brought on by the working conditions. There's still a lot to be done in my member state, and I work a lot not only with the government representatives but also employers in the private sector that are responsible to do much more to ensure better well-being on the workplace. This has not featured very highly so far. Let's just say that we only hear about such incidents, so to speak, is when the employee sues his or her employer for not having given enough attention or for having even been the cause of that person's current debilitating condition. And that is often too late. We have to make sure that we promote and we encourage and ultimately convince even the private sector that this would save money for the persons who are running that corporation, that entity, that organization, because ultimately a person who is away from work is an additional cost to the employer. And once you go down that road of making these arguments, this is when people start to listen to you. One point in particular that I also wanted to touch upon is the issue of technology. I am very passionate about ensuring that the digital single market specifically caters to the needs of those afflicted by diseases and disability. We really need to encourage SMEs and European businesses to invest in technology such as apps and modified websites that simplify access to the digital market. We are still very far away, especially in some member states, particularly mine. We must also create initiatives that will provide necessary training in digital skills for the disabled and the elderly. And by doing so, we can help those who feel isolated to connect through digital technology. There is also this lack of awareness that when we talk about disability, we talk about persons who become disabled as they become older. And that is something that has, let's say, not featured so prominently in terms of policy in some member states, because people treat the disabled and the elderly in completely different departments or institutions, and therefore when you look and you talk about digital access, you think about younger persons, whereas what we are looking at is the most vulnerable of our society, persons who are elderly, who find themselves increasingly limited as they grow older, but there are still many years whereby their condition will worsen, and those years have to be definitely characterized by increased government and corporate action in their regard. Public health and social affairs, what they have in common is that they are not always very fashionable in Brussels these days. And these importance of these areas tends to be neglected. They are accused to stand in the way of cost containment and flexible decisions. But this, I believe, is a misperception. Investing in the health of our citizens is an investment in our future and their future, and especially in the field of chronic diseases. More and more studies show how much is spent in the early stages of prevention, early detection, and early treatment saves later on. Savings which can be reinvested by our governments into societal priorities. And the same is true at the workplace, as I just said. Good working conditions enhance productivity and contribute ultimately, and I attach a lot of importance to this, to the well-being of the persons who are working in that particular place. So, in a nutshell, a lot remains to be done, and let's say the burden of chronic diseases in the workplace needs to be reduced. Huge inequalities persist between different European countries and regions, even regions, in particular member states, and I hope that your discussions today will hopefully be another little step to make work healthier for Europeans. So, thank you for giving me this opportunity, and let me underline that I would be very delighted to continue to work with you on these issues throughout the rest of this mandate. Thank you.
So thank you very much, Dr. Metsola. This was very important, and these were extremely well-received remarks, which also sets the scene quite beautifully for today's conference. And it's now a pleasure for me to introduce to you Marios Kouloumas. He is not only the Vice President PARE, People with Arthritis and Rheumatism in Europe, but he's also a very, very strong partner in our affairs in dealing with rheumatic diseases. And as you are aware, EULAR encompasses 3 pillars. And these are the scientists, the physicians, the health professionals, nurses, physical therapists, and so on. We'll hear about this today, but we are very, very happy that we have the patients as an integral part at EULAR. And this will also be shown at this conference, how important this is. So it is always nice if the president has a very strong partner with a lot of excellent ideas, and Marios is a prime example here. And so I'm looking forward very much, Marios, to your talk.
Thank you, Professor Burmester, for the kind introduction. So, Dr. Metsola, dear delegates, it is a great pleasure for me to also welcome you to this conference, which is very important for the lives of the people with RMDs. I'd like also to thank the speakers, the chairs, the panelists of the participating in the conference today. But also I'd like to thank all of you for attending the conference and for your time and commitment. As a EULAR Vice President representing PARE, the people with arthritis and rheumatism in Europe, PARE, as very correct our President said, is one of the 3 pillars of EULAR, and we are working together under the same roof of EULAR in order to improve the quality of life of more than 120 million people with RMDs in Europe. Currently, PARE has 36 patient organizations as a member from 35 different countries in Europe, and they are very active in raising the public awareness, active in educate and empower the patients, and active in strive and supporting the rights of the patients. Today's conference and the topic is very important, as I said, for the lives of the people with RMDs. And especially now, it's very important to have this conference celebrating the World Arthritis Day, because now the European Commission starting to revising the existing legislations for the safety and health at work. EULAR is very committed to this, and
we are very much looking forward to closely working with the EU institutions and with all the policymakers in order to finding solutions to prevent RMDs, but also to retain people with RMDs and other chronic conditions at work. EULAR is also very proud because we are official partner of the campaign Healthier Workplace for All Ages, led by the EU Agency for Safety and Health at Work, aiming to improve the working conditions of all the employees. I like also to say that these days, we are very lucky because we have evidence, we have data. And thanks to many studies, such as the EU MaskNet, and also the Global Burden of Disease study, we have many data. And today, during the conference, you're going to hear many more data, statistics, and other things about RMDs. But I can say a few things about that because it's very important to identify the problem, because without that, we cannot find solutions. I don't know what's happening with the microphone. Okay. Sorry. So RMDs are the #1 cause of disabilities and impairment in Europe and worldwide, accounting for almost 30% of all the year lived with disability. Among the 10 causes of disabilities, 4 are RMD-related causes, like in the top 2, the pain, the back pain, and the neck pain. To a large extent, inadequate working conditions are responsible for this situation, making RMDs the main occupational disease in Europe. So it's very obvious that improving working conditions is therefore very important, not only for the people with RMDs, but for all the people. For people with RMDs, especially, inadequate working conditions may worsen their health conditions and may... It's my voice, maybe? Okay, maybe because it's too close. So I said that for people with RMDs, inadequate working conditions is the cause that bring them limitations to work, but also lead the people for early retirement and for work limitations. For the people without any musculoskeletal diseases or disorders, the data shows that inadequate working conditions represent a high risk of developing a musculoskeletal problem. This is not only a problem for individuals, but also is an economical and political issue, because absence days, work loss, work limitations, particular for people with RMDs, it is an enormous burden for the healthcare and social security systems. And I can give you just something that we found in Germany, that the total productivity loss as the result of the RMDs stands of 8.5 billion, which represent the 0.4 of Germany gross national product. Finally, work-related RMDs represent an enormous burden for the, as I said, for the healthcare and social security. Some of the concerns that as EULAR and our members we have is, and we like to address this today in our conference, is to improve the primary, secondary, and tertiary prevention of RMDs. There is a need for retention of people with RMDs and other chronic diseases at work, and they return to work after sick leaves. We need to ensure that any barriers related to work for young people should be lifted and should be find solutions in order to facilitate young people to enter the work labor. And also it's very important to facilitate early detections and treatment of RMDs, but also to facilitate the access to occupational health professionals is very important. Also, it's very important to create an inclusive work environment in order to enable the people with RMDs to free disclosure of their conditions, because in many cases, patients are afraid to disclose their conditions because they're afraid to lose their work. I can share with you my personal experience as a person living with RMD, and I believe that thousands of other people is the same across Europe. I was diagnosed from the 10 years old. It was very difficult for me to find a suitable work, and when I was young, I never disclosed to my employers my chronic disease. And when I found a work, I worked for 30 years now in the government. I am very productive. I work fully for the last 30 years, but also I contributed to the society not only from my work, but also as a volunteer. So it's very important for everybody to understand that create an inclusive, adapting working environment. This is important not only for the people with chronic diseases, but also for the society. EULAR is very active in this topic, and I would like to share with you some examples. For many, many years, we have created the EULAR Charter for Work as people with rheumatic musculoskeletal diseases. Back in 2009, it was a charter that we have called for a recognition and awareness. We have called the policymakers to legislate the access to work. We have called the employers to create an inclusive work environment, and also the healthcare providers to support people in order to stay at work. During this launch of the work charter, we have also launched the photo exhibition that you can see the photos in the back of the room, also in order to raise the awareness about this important topic. Of course, you can understand that after 7 years, these calls are very valid also today. Also, EULAR is very much involved in other initiatives. For example, in European level, we have organized together with the Hungarian Council Presidency a conference on challenges in work, capacity and prevention of disability in the EU. But also we have been a partner with the EU Agency for Safety and Health at Work back in 2012 and 2013 for the campaign Working Together for Risk Prevention. Looking for the future, we like to ensure you that EULAR is continue to work on this important topic for the benefit of the people with RMDs. The discussion today is how we all together, especially now that the European Commission is expected to make the changes to the legislation, how we can contribute and how we can make these changes to be effective and implemented in order to create the right working conditions. Therefore, our conference today is very important for this reason. The conference also is aimed to bring together the patient organizations, the health professionals, and together with the EU institutions and other policymakers to discuss and to find the right solutions how to prevent RMDs, and also how to reduction people at work, how to make people stay at work. We want to discuss also the changes at the EU and national legislation, how the employers and the unions and all the stakeholders, they can work together in order to make this accessible work environment for the people with RMDs, but also for all the people who has chronic diseases. As a result of this conference, we wait to see recommendations that they can support this process, and EULAR is going to work to develop this in the next months. Finally, I would like to thank all of you for participating, and I wish you for fruitful and very constructive conference. Thank you so much.
So thank you very much, Marius, for these very important remarks. And it's now time to go to our plenary session, which has the title, How Well is Europe Doing in Preventing Musculoskeletal Diseases in the Workplace and Facilitating People with RMDs to Stay at Work? What else needs to be done? So we'll address this and then we'll come back to this later. And it's a pleasure now to call upon Lorraine Souchet. She is policy advisor at the European Patients Forum, and she will address main challenges in health and safety at work for people with chronic conditions. Thank you very much for coming.
Good morning, and thank you very much for inviting the European Patient Forum to participate to this conference. We are a non-profit umbrella organization representing patients with chronic and long-term conditions in Europe. And our 67 members are patient organizations, which are either national level patient coalition or EU level disease-specific organization. And our mission as an organization is to ensure that patient communities drive policies and programs that affect patients' lives to bring change, empowering them to be equal citizens in the EU. We know that chronic conditions are a major challenge for healthcare systems, but we don't always reflect on the consequences in the employment area. In the EU, 1 in 4 people of working age are estimated to live with a long-standing health problem that restricts their daily activities, and the majority of these health problems come directly from chronic diseases. The Eurofund has said in its report in 2013 on employment opportunities for people with chronic diseases that the participation of people with chronic and long-standing conditions in the job market is problematic in the EU. And this reflects very much the information that we also get from our membership on this topic. While some patients cannot continue their professional activity because of their disease, many continue working or would wish to do so. They may need some support and workplace adaptation or manner adjustment to continue working, but we know that remaining at work with adequate support often results for them in improved quality of life, and it also minimizes some consequences of having a chronic condition, such as the negative financial impact that it can have, or the risk of social exclusion. It is an issue across many diseases, and we have many examples of that on our website that are coming from studies that our members have done, or also coming from other institutions, and I've selected a few examples for you. So the French Diabetes Federation did a study on this topic, and they realized that a person living with diabetes is 4 times more likely to be excluded from their working environment due to their condition. The European Federation of Neurological Associations also published a book of evidence where they say that only 4 in 10 people with chronic pain say that they receive enough support from their employers to manage their job. And they also calculated the cost of chronic pain, which results in more than 500 million sick days in Europe, and it costs the European economy over 34 billion. The OECD has said that people with mild to moderate mental illness, such as anxiety or depression, are twice as likely to be unemployed. And the association Lupus Europe, which is one of our members, has also carried out a study on this topic, and they noticed that while 53% of respondents were still employed, after a few years of diagnosis, many patients leave the workplace, and this is a problem that is common in many chronic conditions. We had a consultation with our membership 2 years ago on this topic, and there are many challenges that our members noted that are common across all conditions. To begin with, patients are sometimes discriminated during the interview for a job when they disclose their condition. We already heard earlier that disclosing can really be a dilemma for patients. There is some data that shows that it can be actually positive for the patient's career to disclose the condition, but on the other hand, there is also a lot of stigma attached to having chronic condition at work. This clausing can also enable a person to use their right to reasonable accommodation, but that if their condition is recognized as a disability, which is not always granted because member states may have different disability assessment systems. Patients also report that they can face negative reactions from employers and colleagues, such as inappropriate disclosure of their condition, lack of support when they return to work after a long sick leave, and even being sidelined. The Eurofund report on chronic disease also indicated that they may have less opportunities of promotion and training in their workplace. What patient organizations also observe is that adapted system and protective legislation are not always in place to allow patients with chronic diseases to remain in the workplace under acceptable conditions and to tackle the stigma that they face. And when these systems and laws do exist, and when patients have clear rights, they are usually underused. Employers and the population at large tend not to know about their existence. Another issue is that the adequate processes are lacking. For example, having a sound return to work procedure is essential for employees after a long-term absence, helping to prevent prolonged sick leaves, lower job quality, or even long-term unemployment. And case review or discussion involving the employer, the employee, and external advisors such as medical, insurance, or health and safety officers would really be crucial in cases where patients need to retire early or quit work due to their condition, but it isn't always there. There is also no particular support in case where patients need to change their professions due to their condition. So many health and safety issues that patients encounter in the workplace are common across the EU. They face negative perception as regards their ability to continue to work safely, low awareness about managing conditions amongst employers, managers, and colleagues, and there is also a lack of incentive to adapt the workplace or make adjustments. In our perspective, there is a key role for health and safety strategies to support patients to remain at the workplace. To begin with, occupational and work-related diseases are an important challenge, and their prevention and management should remain a priority. In addition, our strategies should also aim to support people with chronic conditions at work, whether it is caused by work or not, through developing guidelines and education for employers and managers, identifying and promoting good practices on workplace adjustments, flexible work arrangements, and reasonable accommodation. And also we believe that there is a space for health and safety at work strategies to promote health literacy interventions at the workplace. Health literacy is the ability to use health information and make sound decisions in all areas of life. And the WHO has indicated that such interventions have a positive impact on prevention of accidents and occupational diseases, and they help reduce the risk of chronic diseases. And it usually also shows a good return of investment for employers. So good practices in this area need to be collected, evaluated, and scaled up. More generally, in our view, there are several areas where decision makers need to take action in order to ensure equal treatment and integration of patients with chronic conditions at the workplace. First of all, there is a need to establish appropriate rights and legislation to support patients with chronic diseases, and first of all, to prohibit explicitly discrimination on health status, chronic condition, and provide support to patients that face such discrimination at work. Patients also need clear rights to adjustments and accommodation at work, and there is also a need to improve disability assessment system to ensure that there are no gaps of integration of chronic diseases that cause disabilities. We also think that information, training, and awareness raising is a key area, and we need to take action and have campaigned to raise awareness at EU and national level of difficulties faced by patients and of existing policies to support both employees and managers. For example, we know of some cases in Europe with a website with information for employees and employers, but it's only a few cases, and we believe this needs to be more widespread. We also need supportive, patient-friendly workplaces with appropriate processes and appropriate management culture. Another important point is that cooperation between member states is key. We know that there are some good practices in some member states and they need to be exchanged and they need to be identified. And we also need cooperation across policy areas, healthcare, education, and employment. Here I mention education because discussing with younger patients, we realize that the issues that patients face start in education when they are not adequately supported to study and when they face the effect of their condition. A key recommendation for us is to involve patient organization when taking action on this issue. Many patients have taken action to advocate for the right of patients at the workplace, and they have a key role to play in advocating against stigma. They carry out their own research to better identify obstacles and solutions, and they take concrete initiatives to improve integration of patients at the workplace. We have many examples within our membership of good projects that have been carried out. For example, the EMSP Pact for Employment, which encourage employers to directly commit to set healthy workplaces for all. Or the Alliance Scotland, which led a project, My Skills, My Strengths, My Work, to enable people with chronic and long-term conditions to remain at work longer, or the research carried out by Lupus Europe, for example. So adapting the workplace in order to ensure people with chronic condition can remain at work safely is essential to achieve the goal of EU 2020 on an inclusive growth. We also think that diversity and inclusion are part of a well-functioning company. It's part of corporate social responsibility. And to be an healthy workplace, it has to be inclusive for people with chronic and long-term condition. We think that with concerted action from stakeholders and driven by political incentive at EU and national level, it is possible to ensure patients are better supported in staying safely in employment. Thank you very much.
Please come up to the podium. So thank you very much, Mrs. Sushi. So these were very important introductory remarks to get into our subject, and so it is now a pleasure for me to introduce to you Dr. Rike Helene Mo, and she has a positive statement, which I think is very important. Work is good, R&Ds, clinical impact, and preventive strategies.
Thank you, dear faculty and dear audience. Rheumatic and musculoskeletal diseases, RMDs. There are about, or more than 150 of them, ranging from low back pain and osteoarthritis, as we all know them, to more rare inflammatory diseases. But these are the greatest cause of disability in Europe and a major cause of workless. They affect all ages, but the prevalence increases with increasing age. So I guess some of you have experienced back pain or a sprained finger, and you know how troublesome normal activities can be, like typing, like screwing, like using your hands, or twisting and carrying. People with RMDs have these problems over time. Think about that. RMDs is a threat to healthy aging. It's responsible for 29% of disability in Europe. And if you look at this table of the top 25 causes of global years lost to disability, you see we top the list. But there are positive effects of work on RMDs. And there is strong evidence for the beneficial effects on physical and mental health, on fitness, on psychosocial function, of course on private economy, and on the use of health services, and even reduction of premature mortality. So work is important. So there are a few factors that are crucial to enable successful work participation in people with RMDs. And I'm going to take you through them. We'll start by prevention. Wouldn't it be great if we could prevent all RMDs? We can't prevent all of them, but we can prevent quite a few. By education, as you see here, we can help people protect against RMDs. We can help them take the good and healthy choices in life. We can also secondary prevent by easing societal support for RMDs. Then is physical activity is crucial to the onset of RMDs and also about the burden if you already have RMDs. And physical activity also helps you with weight control, another important factor to prevent RMDs. And then it's timely access to treatment, not just after you get the disease, but before it happens. We can prevent injuries, that's quite important, and we can treat these good, high quality treatment and early, before disability, before depression, and before work cessation, because that is our window of opportunity. Do you agree? Good. Physical activity, as I said, is crucial, and people with RMDs have lower levels of fitness than the general population. And we do know that we can do quite a lot increasing physical activity, optimizing physical activity. We can reduce the pain, we can improve the function and the fitness. And if you recall, those three factors are the top factors that keeps people with RMDs from sustaining at work. So use these more and need less of these. So moving on to treatment, the next crucial factor. Treating people with RMDs is not just treating afterwards, it's helping people achieve a healthy lifestyle. And then there is plenty of evidence that we can treat the pain and we can treat inflammation. We can treat the function and we can improve fitness, not to forget about the depression. And we can also adjust aids and workplace. These are things that we can do that actually works. And if we take 5 steps back and look at the recommended treatments for people with RMDs is as simple as this. You look, everybody with RMDs should have physical activity, education, tailored exercise, and weight control as prevention and as secondary prevention. Some people, they need pharmacological and non-pharmacological care. And then very few people need surgery. And this treatment should be high quality, but it should also be timely, because evidence shows that a delay in onset of proper interventions and delay in physical work adjustments predicts work restriction. So early intervention is more effective. Moving on to education. In the 1700s, John Wesley wrote a book on self-care in the UK, just to give advice on health for the poor. And he was a very wise man, because now, in 2016, education is the cornerstone in RMD treatment and prevention. It's essential for citizens, for patients, for employers, for clinicians to have education on RMDs. We have already mentioned the EU MaskNet project, a joint project where we focused on this. So moving over to adjusting work, another crucial factor. There is evidence that of employer interventions that work. Health promotion at work is and supporting the employee in adjusting physical function when that's the problem. Supervisor programs, there are plenty of them around Europe. Coaching programs, either by the workplace or by health professionals. And adapting the workplace, like physically, with available aids, helps. And a flexibility from the workplace regarding sick days. It may help people with RMD stay at work. And then, really important in some more difficult cases is the communication between the patient, the clinician, and the workplace. So let's just agree on one thing, and that is that most people with RMDs, they can and want to work. Some people can't, but most people can and want to. And then there is some extra effect from workplace interventions, extra supportive workplace. They have even better results. What do they do? Well, they accept functional problems. They communicate this to people with RMDs. They notice the person with RMDs and their trouble. They have a flexibility in the work organization, not also regarding working hours. So, for example, the invisible morning stiffness that many people with RMDs experience, there can be an accept for starting your workday half an hour later, and it may be crucial. Might be that very small adjustment that makes you stay in work. And acceptance for taking breaks when things are painful. If you type and you have arthritis in your hands, you may need breaks. And of course, dealing with problems early, that's also a crucial factor. So, intervene prior to work cessation. It gives us a greater success rate and lower odds of cessation. There are societal interventions important regarding work. For instance, actions to prevent RMDs, like advocating for a healthy work style and available education about RMDs. I already touched by that, how important that is. Timely access to treatment and work adjustments before the problems really become problems. And health systems that can individually tailor treatment and support the workplace to facilitate work participation. An environment is also necessary from a societal point of view that encourages physical activity. So sometimes it's not enough with one intervention or two. Sometimes you have to work on rehabilitation, work on more platforms at the same time. When there are complex problems, they always need more multifaceted help. And you can work at the same time on relieving the pain, helping people being physically active, and making adjustments at work. And this is basically rehabilitation. Rehabilitation optimizes functioning in people with RMDs, reduces pain and disability, and improves work capacity. For example, active coping has a positive effect, we all know that, but you can't learn how to focus on positive aspects of the situation or learn self-management skills and acknowledge your emotions in just a minute or from reading the advice somewhere. You need to work on it. And health professionals can successfully help with this. They can help optimize functioning, match workplace tasks to the individual, and serve as a link between care, the individual, and the workplace. There are available rehabilitation teams across Europe. We already heard about the Fit for Work or vocational rehabilitation or rheumatological rehabilitation. But what's important is that these rehabilitation teams are high quality, evidence-based and coordinated care. And this facilitates early and sustained work participation and improves work outcomes in patients at high risk of work disability. So this may be needed in some cases. So for the last couple of minutes, I've taken you through important factors to enable successful work participation in people with RMDs who can work, because work is good for us. Thank you.
So thank you very much, Dr. Mo, for this very encouraging lecture. And it is now, please would you come up to the podium as well? Thank you very much. And this now gives me a particular pleasure to introduce to you Antonio Camarota, and he will talk about the ergonomics of the workplace, how to reduce the burden of work-related musculoskeletal diseases. And he will present an EU baseline scenario and possible future developments. And so he's from the DG Health and Safety, and so this is of particular importance to us, of course. Thank you very much for coming.
Thank you very much, and good morning, everyone here. I would like to, first of all, express my sincere thankfulness to the organizers of this event, which is very important to raise awareness about the impact of this category of diseases and the importance they have also at the workplace and the role that the European Union can play in make sure that they are adequately prevented at the workplace. In this sense, my intervention today is a little bit more focused than the broader picture you are focusing on in this event. Is about work-related musculoskeletal disorders. And I would like to provide you with, first of all, some data and figures regarding the magnitude of this problem. First of all, you know very well we have heard about it in previous speeches. Ergonomic-related risks are today one of the major health problems in Europe, and they are in particular responsible for work-related musculoskeletal disorders, which are diseases which affect both women and men and all sectors of activity across the European Union. And of course, they represent a major cost burden for business and society at large. This data, part of this data are stemming from surveys, recent surveys carried out by the European Statistics Office, in particular the first one, according to the Labour Force Survey published in 2013, work-related musculoskeletal disorders represent today about 60% of all work-related health problems. So in this sense, they are certainly the most important problem in Europe. They also account for 60% of all sickness absences in the EU and for about 60% of all cases of permanent incapacity to work. The last figure results from a study we carried out some years ago, a few years ago, in the framework of the preparation of an impact assessment for a legislative initiative in this area, and is the data from 2011, 2012, and it's a very conservative figure. But we consider that at least 11 million workers are affected in Europe by work-related musculoskeletal disorders, which represent, of course, as you can see, 5% of the total EU working population. It's quite impressive figure. From the same source, we have some estimates regarding costs of work-related musculoskeletal disorders. They can be estimated at over 163 billion euro. You can see also the, let's say, participation of each actor to this cost. Employers with the 33%, of course, costs for employers are essentially related to productivity losses and turnover costs. For workers, 65% costs related to income and health-related quality of life losses. And for the public authorities, in general terms, impact on GDP, 2%. Very shortly, I would also like to outline the status quo, the state of play as regards the EU legal framework in this area. First of all, this kind of diseases and problems are covered by the horizontal framework directive, which covers all work-related risk, but also includes a dedicated specific article on which states the ergonomic principle of adapting the work to the individual. Based on the framework directive, in principle, all workplaces should be adequately covered by preventive measures, which is not necessarily the case, but what I want to say is, of course, that legislation is there for that. Over the last 2 decades, a number of individual directives have been adopted, focusing on specific area of exposure to risks which can determine musculoskeletal disorders, directive on manual handling of loads, and work with display screen equipment adopted both in 1990 and in 2002 the directive on vibration. There are also a number of other directives which, let's say, are directly linked to the work-related musculoskeletal disorder and the prevention of ergonomic risk. For instance, directive on workplace, on work equipment, and the whole package of directives related to machinery, which are intended to ensure a common safety level in machinery placed on the market or put in service in the member states. Next to regulatory framework is also needs to be mentioned a number of important non-regulatory initiatives, in general terms awareness-raising initiatives. It was already discussed, mentioned the important role of the EU OSHA, the European Union Agency on Safety and Health at Work in Bilbao, which carried out 2 campaigns on MSDs in 2000 and 2007, respectively. Another important consultative body in the area of occupational safety and health in Europe, the SLIC, which is the acronym for Senior Labour Inspectors Committee, carried out a biannual campaign in 2007-2008 on the enforcement of the manual handling of laws directive in a number of sectors. And it goes without saying, there is a lot of initiatives at national level in the area of awareness raising, production of guidelines, and so on. Some figures again regarding this time trends in the prevalence of work-related musculoskeletal disorders in the member states. This data come up from a survey carried out in 2009 in the framework of an initiative developed by the Advisory Committee on Safety and Health at Work, in particular by the government interest group, to implement some provisions of the former EU OSH strategy 2007-2012. A questionnaire was sent to member states and on a number of topics. One of them was the trend as regards the prevalence of work-related musculoskeletal disorders. And as you can see, at that point in time, the results of this questionnaire showed that there were decreasing rates in only 5 member states. 2 member states show stable rates, while the remaining member states showed consistently increasing trends. In general terms, what can we say about future trends? First of all, this is something that has been touched upon, and I suppose that will be focused on later again in our discussion, is demographic change. The fact that more aged people are working longer in Europe, and future trends are indicate that they will probably work even longer in the future. And of course, you know very well, there is a positive correlation between workers' age and the likelihood of reporting work-related health problem, and in particular in this area of chronic diseases. Another important aspect is the change in the sectorial composition of European economies, increasing role of services sector and decreasing role, relatively decreasing role of a traditional industrial sector. This has an important impact in terms of prevalence of certain type of exposure to risk. While in the past, for instance, the manual handling of loads was the most significant area of risk, which could determine musculoskeletal disorders. Repetitive work today is the most important source of risk, for sure, for different reasons. Repetitive work is linked to a number of activities, last but not least, for instance, to the use of computers at the workplace. A last point I would like to raise today here is more a question that's a statement, and it's about probably the need to refocusing some of the existing provisions, which may need to be updated or complemented. Particularly, I'm thinking about the directive on work with display screen equipment, which was produced at the end of the 80s, and of course, in the meanwhile, quite a lot of things happened in the area of ICT. One thing is certain, given the current levels of prevalence, as well as the dynamic of future trend factors, as we have just seen, it is unlikely that the problem can be substantially reduced without additional action. What is the role of the Commission, of the EU in this framework? First of all, I would like to remind you about one important principle which has been reinforced by the new Commission presidency, by Mr. Juncker at the beginning of his mandate. The Commission is very, very much linked to the principle of subsidiarity and proportionality. You know what it means, more or less, I suppose. Subsidiarity means that the European Union should intervene only when there is a significant and important European added value for its action. In other terms, if you want, we should avoid having doubling initiatives from member states, for instance. And on the other hand, proportionality, that means that we need also to design political tools, instruments that are capable to deal with the problem effectively and efficiently, but also avoiding any unproportionate burdens to the actors, in particular in the area, of course, of economy and business. It was mentioned earlier on, we are in the process of, still in the process of this evaluation of the legislative acquis in the area of health and safety at work, which is part of the broader refit program of the Commission. The results of this exercise are expected by the end of this year. And of course, they should contribute to providing a clearer view of what can be achieved at EU level and what can be left to the initiative of the member states on the one hand. On the other hand, also they should provide direction in identifying the most appropriate way to move forward with initiatives at EU level. Just to, and I'm closing, I'm very close to the end of this presentation. One word as a general outlook, perspective for the future. I think that the point where we can, at European level, we can improve, and we can dramatically improve, I think, is ensuring better synergy between EU and national initiatives on one hand, and of course in this sense it is very important the role that institutional consultative bodies already existing, such as the Advisory Committee on Safety at Work can play in ensuring the interface between European and national level. Improving the synergy between the two levels of OSH governance, I would say, on one hand, and of course a stronger emphasis on assistance for better implementation and enforcement. As I said at the beginning, this framework directive is covering all the occupational risk in principle. Then we know that there are problems. These problems can, on one hand, be the result of an ineffective legislation. This is always possible. We will see what the results of our evaluation will be. But on the other hand, maybe we need to ensure better implementation and enforcement of the existing provisions. And I think this is surely one of the main avenues for improving the situation with work-related musculoskeletal disorders. Thank you very much for your attention.
So thank you very much, Dr. Kamauta, for these very important remarks and for giving the view of your agency. And so that is, oh, sorry. So again, I would like to thank you for this very important contribution. And now we proceed to the patient perspectives, and this will then be presented by Marius Kulumas again. And I promise you some interesting survey results of the patients in Europe and how they feel these problems are dealt with. Thank you very much, Marius.
Yes, thank you. Good morning again. I would like first to thank my colleague, Dieter Wick, the chair of the Standing Committee of PARE. He canceled his participation in the conference because of health issues of his wife. So we wish her all the best. And just to say to you that we acknowledge and thank him for preparing this presentation, also analyzing all the results of the survey that we have sent to our members. So I'm going to present to you the views of our patients, the views of our patient organizations about the topic that we have discussed today. First, I'm not saying a lot of things about this because you have already said that PARE is the patient arm, one of the three pillars of EULAR, representing the patient organizations in Europe. And we have 36 patient organizations as members, and is the voice, PARE is the voice of the patients. Before we go into the results of the survey that we have conducted with our members, I would like to give, just to set the scene of the topic and to give some data that we think that is important, in spite that we said a lot of things about data and statistics. It's very good also to again and again to highlight the importance of the topic. So this is a sick leave duration for people with rheumatoid arthritis. Data that we have gathered from Germany. And as you can see, we have improvement in the sick leaves. And this is due to the effective treatments that we have today for the people with rheumatoid arthritis. But as you can see, there is still a problem. Also, the employment rates of patients with rheumatoid arthritis and ankylosing spondylitis, also their employment compared with the general public, with the general population, is also limited. Also, you can see here that compared to all kinds of health issues, musculoskeletal problems are the most common of health problems in the EU working age population. And if you can see there is the top one, the third, and another one down. So is the highest health issue compared to other health issues, the musculoskeletal disorders. So we like to also show to you that a person should have a fully productive when he's in the work age. But if you have a rheumatic or musculoskeletal diseases, and then you start to have sick leaves, if you have not the adequate working conditions and support, and then you have limitations to fulfill the task and the job, and finally, you go to early retirement and you lose your job. And this is the problem that we should find solutions to cope with. So we ask our members, organizations, how they see the current legislations and policies for the RMDs in the workplace. We have received 19 responses from our members. So we first ask if they are involved in activities dealing with occupational safety and health issues. So as you can see, our members, they are very actively involved in this area. And we have 14 out of 19 organizations answer that they are involved in activities aiming to prevent the onset or progression of RMDs in the workplace in some forms. And there are many examples of good practice, how our organizations, they are involved in this area. And we can use this in order to find the best solutions, how we can, our patient organizations, but all the stakeholders can working together in order to cope with these issues. So because we already discussed the awareness, which is very important in order to understand everybody involved in this topic, the problems about the access to work for people with musculoskeletal diseases, we have asked about the feeling, about the views of our patient organizations. How is their awareness between the policymakers, employers, and society? Although the awareness for the general public is rated higher, there is a need, I think, to raise the awareness on this topic, having in mind that no one said that employers and policymakers are very aware. So we can see that also the public, the general public, are not fully aware, but it's something that we should worry that the employers and the policymakers, the people that they have to take action on this, the patient they don't feel that they are aware about this importance of the topic. There also seems to be a lack of employer support for people with RMDs in adapting their workplace and meeting the needs of these workers, with 74% of respondents says that employers were not supporting employees well. Issues such work loss, early retirement, and disclosures of the disease seems to be related to this behavior. So this is very important for the patient organizations. Also, we can see that for the national governments, you see that the half of the governments, they feel that it's important, the topic of access to work, but none of the governments, it is the top priority in their work agenda. So this is something also that we should improve. how about the prevention of work-related RMDs? We wanted to find out how our organization judges the existing occupational safety and health legislation and policies. What we see from the responses is that there is not many countries, that there are many country legislations, but are not effective. But also in countries that they have legislations and they are effective, they are not fully implemented. So we should have legislations, but in the same time, we should implementing these legislations and policies related to work conditions. So about the progression of non-work-related RMDs, only 26% of respondents said that existing legislations and policies were effective to slow down the progression of non-work-related RMDs, such as rheumatoid arthritis, with over a third of the countries not having legislations and policies to address this issue. Even in countries where legislations and policies were rated as effective, there were problems with implementations. So we see that implementing policies and legislations is very important. So about the retention of people with RMDs, we see that 79% of respondents said that existing legislations and policy were either not effective in retaining people with RMDs in their workplace, or there was not legislation or policy on this, with only 21% say that were effective. Nobody said that they are very effective. Return to work after treatment for people with RMDs. Only 21% of respondents felt that existing legislations and policies were effective to allow people with RMDs to return to work after treatment, with almost half, 48%, saying that existing measures were not effective, and only 21% said that there is not existing legislation or policy on this in their country. So for the young people with RMDs, which of course entering the labor market is very important, 43% of respondents thought that existing legislation and policies were not effective to allow young people with RMDs to enter the labor market. And 21% say that existing legislations and policies do not address this issue. And it is one of the most important things that governments and EU should legislate in promoting, facilitating young people to enter the labor market. This is important not only for the young people, but also for the society. Access to occupational health professionals. This seems to be an issue across Europe, with over half of the organizations, 52%, classifying existing legislations and policies as not effective. And a further 11% say that existing legislations and policies do not address this issue. What about the coordination between the different departments and ministries in the national government, between the labor, health, financial ministries? As we can see here, there is a lack of coordination between these departments. And this is, we believe that it is a problem, because all the issues around health, access to work, is not only a health issue, it's also a financial issue, it's also an issue for the Ministry of Labor. So they have to coordinate their efforts and their policies. So finally, we ask our members for their recommendations for the policymakers and for the employers. Of course, we have received many suggestions, and we have a very comprehensive list. We just selected for the conference now to show to you, and we can send in a later stage or discuss later all the suggestions. These recommendations that we believe is the most important. Of course, all are very important. So to provide occupational health services, to provide financial incentives to employers in order to facilitate and to adapt their work environment for the patients and for the people with RMDs. Adopt legislations to accommodate flexible adjustment working hours for people with RMDs. Support small and medium-sized enterprises. This is very important because there are financial implications if you ask employers with the small or medium-sized enterprises to make these adaptations. And improve vocational rehabilitation. And also we have the recommendations for the employers. So consider employee health as an investment rather than a burden. So we should address this because it's important not to speak about burden and cost, but investment. Adapt work environment to individual needs and not the person to the work, but we should adapt the work to the person. Adapt working hours for individual needs, change perceptions and attitudes, and this is very important to raise the awareness about these things in order to change these perceptions. React quickly in order to prevent deterioration of the conditions and adjust their workplace so that the people without RMDs can also benefit. And of course, with these policies will benefit the whole society. So thank you for your attention.
So thank you very much, Marius, and of course Dieter as well, for giving us the very, very important patient's perspective. And now I guess these lectures have beautifully set the scene for a question and answer session. We are perfectly on time, so we can accommodate many, many questions. And I'm sure that you have some already, and maybe Neil, you want to start this session with a question?
Yeah, thank you. It's something that maybe combines elements of what all of the speakers have touched on. My experience in the UK working with a patient organisation is that sometimes individuals with an RMD don't always identify as a disabled person, and that many of the mechanisms, the legislation, the social adjustments that need to take place are sometimes only triggered when there is some connection with the sort of disability rights issue. So I'm wondering whether we need to be looking at part of the solution here being better education via patient associations and maybe through healthcare professionals and clinicians to encourage more people with RMDs to at least explore their rights, even if they don't want to identify personally as disabled. Because I think there's a suboptimal use of resources there. And Antonio, your point about enforcement and monitoring to try and make what is already there work better, it seems to me we need a sort of bottom-up and a top-down approach. So the question is there some scope for collaboration between patient groups, healthcare professionals, employers and trade unions who all want the same thing really, which is to get the best value out of their employees by supporting them better?
Yes. Please use the microphone, yes. Mm-hmm.
Synergy is the golden word to use in this area, not only in this area. I think when we try to design new policy tools today, we have to consider different instruments that need to be used. As I said, legislation is one of them. Yeah? Probably, at least in this area, we have already consolidated a number of important achievements in terms of legislation produced, but we have to do a lot in order to make sure that legislation is well implemented and, of course, well enforced. And that means to, in general terms, to build a culture of prevention, of course, but also a culture of for people with disabilities who are more can have their an easiest access to the labor markets. And in this sense, I think that all actors need to play their role from different perspectives. And as you said, in order to integrate, complement each other, the bottom-up, the top-down approach.
I think, Vicky, you wanted to add something? Yep.
Yes. I'd like to add to what you just said about the culture for openness. That's quite important, and I think we have to again take a few steps back and maybe start with education at school, educating everybody about the diseases and about another attitude to these kind of problems that counts for at least some in our families already. I mean, almost every second person will have RMDs. So I think we need to think about educating people and think about attitudes already in children.
Thank you. So questions? Yes, please. We have the microphone there. So
If you can, Antonio, deactivate your microphone.
thank you. Okay, now it should work. And please introduce yourself and the affiliation. Tony?
Tony Wolf from the Global Alliance for Musculoskeletal Health. I think health protection is extremely important, but we've seen that it's not solving the problem, that the numbers are still going up or staying the same in many countries. And I agree implementation is key, but I think we have to look at other components. And one is, as was being said, about making sure that the work environment is receptive, supportive, inclusive, enables people to talk about their problems, because we hear an awful lot about stigma around mental health, but I think there's just as much stigma around physical health and people saying that they're physically not capable to do their job, and this is not recognized, and it leads to ongoing people sort of trying to cope without the support they need.
Yep. So,
Anyone want to comment on that, or we ask? Yep. Yes, please.
I agree, and like I was explaining, this is a problem that starts even for young patients. We often think that chronic condition is a problem of old people, but there's already 10 to 15% of adolescents that have chronic condition, and when they are at school or at universities and they have absences because of their illness or other things, they often don't face the right reaction already there. So I think it's really a
Elsa?
Okay. On Monday this week, I believe Macmillan released a very important report, which I think is echoing what everyone is saying. And that showed that out of a survey of over 1,000 line managers, 4 in 5 had had no training in how to support people with cancer and long-term conditions in the workplace. And they thought that it was actually very difficult to do this. But then a quarter of the people who had actually supported people in the workplace said that it wasn't difficult at all. So I think you're right. I think education in the workplace for line managers is going to be crucial. But then how do we incentivize employers to actually take that on board and do it?
Yep. Thank you. There is a question right in front of you. And then we go to the right-hand side.
Yes, I agree with you when you talked about culture and the change of culture and education from an early age. But as we know, culture, it's not so easy to change. So I would think that legislation, but also implementing this legislation, it's very, very important through the Commission. But I don't know how does this work, as we know that there is no common health policy. But I think we need to find a way, sort of impose, I don't know, find a way for the employers to implement this legislation, because otherwise it takes very long to change culture, especially in some European countries. So, and I agree with you, Esla. Thank you.
Tony, you want to comment, or yep?
Just very briefly, I fully agree with you. I mean, this implementation, as I said, is the key approach to the problem. On the other hand, I must say, for instance, also to reply to one of the previous question or comments. Once again, legislation is there. For instance, regards adapting the workplace to the individual. I mentioned, and it's there from the Framework Directive, which is a directive from the '89. So the obligations for employers to prevent, also in terms of adapting the workplace to the individuals and to their specific needs, including people with disabilities, of course, is there. Now, how to make sure that this is correctly implemented, or is implemented at all? And this is exactly the point. The Commission is fully aware of this problem, of course, and we have tried to also to develop a number of other instruments, political instruments, to make sure that at least we can coordinate some initiatives at European level and among member states. As you may know, in 2014 the Commission adopted a new strategic framework on health and safety at work. One important chapter of this strategic framework deals with the prevention of chronic diseases and health conditions in general due to exposure to work risks. There is a lot of things happening. In particular, I mean, I would like to mention once again the very important role played in this sense by the European agency in Bilbao, with its campaigns, with its initiatives. But of course, as you say, culture is not changing overnight. That's clear. One important initiative in our pre-meeting yesterday afternoon, I mentioned that. I think it is important to mention it again now. Here is that we are working on what we call EU OSH information system. This should make sure that information, which is also today is quite dispersed from different statistical sources, or even results of surveys, for instance, is in a way put together in one OSH information system at European level. This system should be operational. We hope it will be operational as from 2018. It will be visually accessible via the ICT platform, the Bilbao agency. And what we intend to do with that is exactly to know better how things are in Europe. Because when we talk about OSH policy in Europe, we are talking about a very abstract entity, Europe. But Europe, as you said, is very different. There are a lot of differences, and differences have been increasing dramatically, I would say, after the last wave of new member states joining the Union. So we need to know more and better where the problems are, how we can better tailor our initiatives in order to take the problems where they are, and how we can also, as member states, we can learn from each other, from good experience, from better practice, and so on. the future. Information on one hand and better support for implementation.
Thank you very much. So maybe I can take the chairperson's prerogative and ask a question, for instance, to Ricke. So let's say I'm an employer and I don't believe in implementation at all. I think this is all a nuisance. People come in, inspect the workplace, and with the new chairs and new screens and whatever. I say, well, I don't really have the money and it's of no use anyway. Do we have data to support, actually to go to the employers and tell them, well, you really save money and this is the percentage that you save? Are these data available already? Probably did you some investigations, for instance, in Norway, looking into companies that implemented it and into those that didn't, so that you can really convince with hard data the employers to implement it? I think that probably would be extremely helpful.
Yes. Yes. We do have these data, and they are positive. They're really positive. And we have data from the Scandinavian countries, and we have data also from the UK. We have data from now Spain, the last country out, I think. The really positive numbers that we can use in discussions. And I also think that from the previous discussion, just to emphasize again the importance of support in disclosing your problems, the support that health professionals and clinicians can give people with RMDs are valuable. But then again, I have another question, because many times there's a barrier from the people with RMDs that if they disclose their disease, they will have problems with insurance. So could we do something about that?
Who wants to comment? This is a little bit complicated because the insurance system is so different from one country to the other one. I mean, I know this in Germany, if you have a severe chronic disease, you do not enter a private health insurance company in our country, but you wouldn't face tremendous problems in the public sector currently. Yeah. But it's quite complicated. Mm-hmm.
But we could maybe compare it to pregnant women applying for work, or they do not have to disclose their pregnancy, and so they shouldn't be treated differently because they are pregnant. So it's kind of the same thing, I think. So maybe it's a political question as well.
Marius, you want to comment?
Yes. Yes, I just want to say about the incentives for the employers, because it's very important, the directives, but also to discuss this, how we can change things and how we can implement things. But it's very important to give incentives for the employers because they are small and medium enterprises that they cannot afford to make the adaptations or to make all these prevention measures. But also there are some positive measures from the governments in order to change the culture and the awareness of these issues. For example, I will mention from Cyprus as a good practice. For the first time, the Cyprus government this month has launched a working scheme for the people with chronic diseases in collaboration with the chronic patient organizations. And this scheme says that for 12 months, they're going to support the wage of the people with chronic diseases, employment. For 12 months. And this, of course, allowed the chronic people to employ in the private enterprises, but at the same time, raise the awareness and show to the employers that if you hire a person with chronic disease, and then you can benefit for that they can also reduce the stigma of this issue. Another positive measure and policy from the government in Cyprus is that for the public sector, 10% of all the empty positions is for people with disabilities. Also, this is a good measure, it's a good policies in order to promote and to facilitate the employment of people with disabilities and chronic diseases.
So thank you very much, Marius. I'm afraid and delighted that we have so many questions. We can only accommodate 2 more. So the gentleman in the back, and then to René, and then we'll have to close this session. But please remember your questions, because there will be a panel discussion in the afternoon, and then we can certainly accommodate many of your questions as well. But we'll have to close after these two questions now. So please, the gentleman in the back.
Tijan from the Swedish Rheumatism Association. I just want to get back to the implementation of these things and the rule and regulations with that which every country is having. The question is, have you been thinking about involving the labor union for the implementation of these things? Because I think they could really look after the workers and look for their benefits.
I think that will be exactly one subject of the workshop. And I think we'll come back to this later on in the report, and maybe Hans, and then you can allude to this, because that is obviously a very, very important question, but we'll come back to it later. So the final question by Professor Westhofens. So, René.
Yeah, thank you, René Westhofens, Royal Belgian Society of Rheumatology, so I'm local. I think many things are said, and there are many things happening, though the figures go down. So it's worsening. And I think Tony has right, and many people already alluded to that, it's all about implementation. I'm not an implementation scientist, but what I understand from implementation, that you have to look for hurdles and opportunities. And you can make a lot of legislations, but when you're not facing the hurdles or not identifying the hurdles and the opportunities, you will never succeed. So we have definitely to look to that. And one of the things are said by our Norwegian colleague, there is some evidence, perhaps not enough. I think there is, from my experience, and I'm seeing patients for 35 years now, bringing a patient with a certain impairment in a labor situation is not only good for the patient himself, but also for the colleagues of this patient in this working situation. It's a kind of role model that stimulates other patients to have pleasure in work, seeing this patient with a certain impairment performing. So this is one of the opportunities we definitely have to take, bring into the picture the role models, because these are opportunities to influence the local employees, but also employers. I have one negative experience, and we are a lot of nurses here, for instance. I have several patients with juvenile idiopathic arthritis that were treated and are in a good condition at the age of 18. And because they were in the hospital, they would like to become a nurse. And imagine what happened if these student nurses come for the first time in a working situation with other nurses. The first command they get, you will never become a nurse because this job is too heavy for you. So we do negative things and we have opportunities. So we should really look into the opportunities, and for instance, in some working situations like nurses associations, we should perhaps think about that. The same holds for people that are in sports situations and for any one reason, for the disease cannot perform as well as it would expect it. So we should go to these organizations and organize meetings to identify the hurdles and also show the opportunities.
So thank you very much, René. There couldn't have been more interesting and better remarks towards the close of our session. So I'm very sorry that we now have to close this session, because we will, of course, we have the important workshops ahead. And that gives me the opportunity to thank very much all the panelists for the very, very important contributions and the deep insight into the problem. We haven't finished our day yet. We just have to start the work now. So there will be a coffee break of roughly 15 minutes, and then you may want to look at your name badge, and there is a number that signifies the workshop that you are assigned to, because we want to have roughly even numbers in each workshop. And after the workshops, there will be lunch, and finally, then we will report about the outcomes of the workshops, which of course is very important. So please go then after a coffee break to your assigned workshops, and
work hard, and then we'll see each other for the reports. And so thank you very much, all of you.
important to prevent, for instance, remarks
quite dispersed from different.
E, E, E. E, 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 E. E, E.
So stimmt es, ja?
Ja.
because once the
Yeah, that's
they
so.
can
So
use-
they give the report from here.
well, as they wish, that's a
Okay.
good question. They can either do it from there or they use the ticket here. So this is just to the right.
Okay, fine.
So I will leave this here
Hello.
with you.
Hello, get Melissa. Hello. Yes, I know. So I will introduce you, and I will introduce the guests, and then you'll have the podium.
So you'll introduce the guests, or I
It depends. You want to introduce them? Because first, yeah, probably easy better. Yeah, because then So because the script says I should do this, but I guess it's better if you do. Because you're the moderator and you will. Yeah. Okay. Listen, yeah, exactly. Yeah. Okay, I'll do that.
And then go and hand back to you at the end.
Exactly. So let's have a look. What I'm supposed to do. So now we have reports of the workshops, and then I'll hand over to you.
And then the
And if you introduce these members. Okay, very good. Thanks a lot.
You can stay here during
The plenary?
the feedback.
Workshop. Oh yes, of course. Of course. Yeah, yeah. Just for the feedback.
Slightly higher or just around?
No, why not? So you learn exactly the same. No, it's always good if you have two persons who are
Talk.
something. So, ladies and gentlemen, I think it's time to start again after a nice lunch. I hope you enjoyed lunch. You're probably still digesting it, and nevertheless, I think it's now time to go into the, I think, exciting presentations of the workshops. I went to all of them, and I saw that there were very active discussions at the table, and so I would also like to ask the workshop leaders to come up front. I guess the first one will stay here for the podium. Are the workshop leaders all here? Yes, could you please come up to the podium? Annette, and the missing one workshop leader. But I think Hans is there already. And who is the? Yeah, right. But the other, Elsa's there. Perfect. It's if you, yep. Oh, that's fine. Oh, I don't know who to put you in the back. Okay. So thank you very much, and now let's go to the first workshop, and it will be presented by Hans Belzma.
So in workshop number 1, we had a very active group working together, and we had 3 different round tables with the discussions going on, and it was very lively and everybody participated, so I would like to thank everybody for his or her input in our sub-meeting. So the background of our thinking, our discussion was that, as Antonio Camarota explained to us, there is now a moment that there is a second look at the legislation which is relevant for the safety at work, for the prevention of diseases, and especially the rheumatic and musculoskeletal diseases, to think about what input we could give to those people. So safety at work is of course a legal responsibility. There's a framework from the EU and a lot of national legislations, and they have been shown to be very effective. For instance, reducing the manual load is an important item that came about by this legislation. But we think that it needs some update in some areas, and also we hope a simplification, because we realized that too much regulation is really fighting against the individual responsibility. And that was an item that came on our discussion, and some of the slides are relating to that. So this was the title we had to look at: the prevention in the workplace. What legislation and policy initiatives do we need? We had 4 questions that we were discussing. The first question was the identification and discussion of the main working conditions causing RMDs or affecting people who already have RMDs. The second one, identification of possible changes in working practices that could better prevent RMDs in the workplace. The third one, identifying of gaps in legislations and policies at both EU and national levels that could further prevent RMDs. And then development of recommendations to EU and national or even regional policymakers, employers and other stakeholders. And we came up with some items, in different order than the questions, but I think this is more logical. So what changes to working conditions are required to better prevent RMDs at work? And the first item, which is in line with what I started to discuss about responsibilities, is to make it clear to the workers, but also the co-workers, that they have responsibilities themselves. Responsibility in recognizing what's going on, responsibilities in telling what's going on, and responsibilities in trying to solve it as much as possible at the workplace. So that will ask for a creation of a culture of support at the workplace, by the employees, as you just mentioned, and the co-employees, but of course also for the employers, the trade unions, the payers. And one of the items that came up in all the groups was quite clearly to avoid stigmatization and to culture a culture of empowerment. And then the focus should not be on what is person not able to do, but the focus should be what is a person able to do. So the capacities of the individual person are very important, and we should focus on that. Also, we think that organization of and participation in education and training is very important. That accounts for the employees, but also the employers, also for the states, and also for the payers. And this will lead to a promotion of health literacy. So if you don't know what to look for, it's very difficult to see it. So if you know what to look for, you can see it. And of course, it's very important that if something happened to a person, that the culture should be that it will be more easy to go back to work, with adaptation or without adaptation, but also not only the physical activities there, but also the mental activities of that person, but also the co-workers, is very important. So then the question came, what should policymakers do to better prevent RMDs in the workplace? So the EU, to adapt current legislation to new needs arising from changes in work patterns and organization. In the past, many people were doing manual work, and now many people are sitting, or some of them are laying behind the computer. And the digital area, of course, has different requests for the pattern in work and organization. Then we thought it might be better to propose guidelines than new legislation, because guidelines are of another order for the people, and the guidelines is much better to be followed than when you have precisely described how exactly it should be. So guidelines for implementation of EU legislation. We have no good idea how much the legislation is implemented. We had the question around the table whether we really knew gaps in the legislation, if people came into problems because of lack of legislations, and in fact nobody had a good example for that, so perhaps it's not that bad, but of course most of us, and I will excuse of course the people who have a full-time job, but most of us, like doctors and health professionals or patients, are not completely aware of all the legislation that's out there. So it should be implemented and then see whether are there really gaps, yes or no. And we also came to, if you are having discussions about disability, if you're using different definitions of disability, it's quite difficult to speak with each other. So that's also an item to think about for the EU institution to better define what they mean by it. Then, of course, the letter below that, you have the member states or the regions. To overcome the separate approach of health and social systems. So quite often you can gain some money in the health system, but then you have more burden on the social system and vice versa. So if you really have to see them together and then find out the best way to go forward. So what is stimulating people to do changes? The incentives. And if you want a company to do something really good for the employees, so fit for work or having other activities, perhaps you could find an incentive, and an example was given, if you have a tax deduction, if a company is has a very high level of patient-friendly, of employee-friendly work and so on. So that's an item to look at. And then the promote business case of prevention awareness campaign could also be done at the level of the national member states. What should employers and other stakeholders do to better prevent RMDs in the workplace? Well, to propose incentives for prevention and healthy lifestyle, so at the individual level of the employees. Then flexibility is very important. Flexibility towards adaptable workplaces and to work organization. So again, look at the capacities of the person, not of the disabilities of the persons. Also, it's very important to have a proactive response to early symptoms. So people don't have the culture, well, I'm getting a swollen finger, I won't mention it because what do people think about it? Well, if you mention it in time, you can have early intervention and the outcome will be much better. So proactive response to early symptoms. And then, of course, compliance with existing rules that are not there for nothing. Other stakeholders, well, you can mention a lot. We discussed a little bit about the trade unions. So they could participate in the risk assessment and in the intervention design and then give individual support to their members who it involves. That was what we discussed in workshop number 1. Are there questions about this report? Or
Can we add to it? Yes, thank you very much. So that was a very interesting workshop. Maybe I have one question. Did you also discuss that there are, let's say, at certain companies there might be some sort of an alarm clock ringing if you have so many people being absent from work, and maybe some research in the companies how much is due to RMDs and other conditions so that you can act upon it?
It's a good point. We didn't discuss it. It's a good point.
That would be something that you know. Let's say
You
because
could think about
I'm an employer myself, and of course I don't know why someone is absent from work. Sometimes they say it, but sometimes not. But if this could be done anonymously, then we would see, oh, there's a red flag, we need to do something. That might also be something.
So there is some evidence out there that if you have an early response to sick leave, then the reintegration is much quicker and much better. So the evidence is there that we should really look at it. So that's also the proactive acting to symptoms and sickness, etc.
Yes?
I think it was, we had a discussion on that, Hans, but not in the feedback, so you didn't hear it. I think it was our colleague William from EULAR who mentioned it, that it's quite difficult sometimes to make that connection between prevalence of RMDs in a particular employer or even sector, because you're never quite sure whether it's the actual occupation that is exacerbating or leading to the disability or the worsening of the RMD, or lifestyle factors related to those individuals outside of the workplace.
Yeah.
So there might be some socio-economic factors or factors to do with the type of work or the type of institutional sector. So quite difficult to disentangle, but doesn't mean we shouldn't try to look for any red flags like that. Good.
Okay, other questions? No, but maybe we... there's one in the front. Please hand over the microphone, yes.
Have you looked into the importance of the presence of people with having an illness or having a disease and working without, not at 10% level, is working all day, but at half his
part-time work.
No, not part-time, all time.
Capacity, I'm sorry. Capacity.
Yep.
Yeah, it's clearly there as an item, but we didn't discuss it separately because we had it already in the presentations this morning that that's part of the whole spectrum that we have to deal with. But you're completely right, it's there.
Okay, thank you very much. And okay, yes, the microphone is coming.
Thank you. Just a remark on one of the priorities, I think, regarding the prevention being a responsibility of individuals. I would like just to say that for me, prevention is first a responsibility of the employer, and second,
that's how I started. I started as a legal obligation. That's how I started. Yes.
It's a legal
we
obligation,
know that,
a responsibility, and it has to be collective first, and then individualized if the collective fails.
Because the implementation is not as good as it should be, and we can see that there is gain to get there. So that's why we say that I started with it's a legal obligation.
Thank you.
Okay, thank you very much. It's time to proceed to the next workshop, being presented by Annette de Tura. It is on access questions to occupational therapy, physical treatment, and other questions.
Yes, I would also like to thank you, the very hard-working workshop. We had some good energy and very fruitful discussions in our workshop, dealing with RMDs in the workplace, how to improve access to occupational health professionals and therapists. And we also had you can see these 4 questions here. We had 3 questions, and the main challenges, the first question was main challenges for people with RMDs to access occupational health professionals and therapists. And one of the first things that was brought up was the the question about awareness, that people with RMDs needed to be aware what could health professionals actually do, and also how to find them, because it wasn't so obvious all the time what could health professionals bring to the table. And also transparency of process and outcomes, and that was regarding evidence, so that the things that were brought to the table was based on evidence, so that patients knew what would come out of, for example, going to a physical therapist or occupational therapist. And then the next thing was quality control of that evidence, meaning that the reimbursement should sort of follow the evidence, so that if there was good evidence for physical therapy or occupational therapy, then the reimbursement should follow that evidence, and not the reimbursement should not follow things that wasn't evidence-based. And then qualification and perfection, which was dealing with training and education of specialist health professionals, because as you may be aware, there's a huge variation across Europe on health professional specialists' care. So in some countries you have high specialized health professionals, and in some countries you don't have that same access. So, and what should policymakers do to improve access to occupational health professionals and therapists? We were talking about cross-sectoral cooperation, meaning that there should be some more flexibility across sectors, and also the same thing that I was referring to earlier, benchmarking and best practices. We should sort of bring forward the things that we know work, and at the same time funding of randomized control studies on vocational rehabilitation, because this is an area where funding is not so easy like in many other areas, and at the same time you need to have rather big studies and follow patients for a very long time to get good evidence, and that costs a lot of money. And then criteria for networks of excellence, so that people know where to find each other. And then also on the member state, regions level, we had this discussion about the flexibility of cross-sectoral cooperation among ministers and departments. And then at the employers level, awareness, and I think that was comparable to what the earlier group was mentioning, awareness of employers of taking ownership, productivity benefit of patients staying at work, so that employers knew that they would actually in the long run benefit from taking action on this and taking ownership. And other stakeholders inform suppliers about available support, which meant where do employers actually go for information about what is the right thing to do? Can we in any way support employers so that they have access to this information about what can health professionals bring to the table here? And then from patient organization and all stakeholders, information, because we think that in the long run there is a lack of knowledge about what can health professionals bring to this area of vocational rehabilitation. So we need to inform and be more proactive in informing about these intervention types. Yeah.
So thank you very much. Excellent. Questions? So yes, please. So we have time for 1 or 2 questions, and then we have to move on.
Did you also, thank you very much for presenting the interesting results. Did you also talk about if a standardization of qualification of the health professionals could improve acceptance also in the field of rheumatologists, for example? Because I'm coming from Germany, and there this also seems to be a problem.
Yeah. It was mentioned in some of the work in some of the groups, yes, that some sort of standardization, so that we have some standard, and that actually that was a little bit what was meant about the benchmarking part. Yes.
Okay, thank you very much. And now the final workshop. Elsa Bothworth and Brenda O'Brien. What about retention and returning to the workplace?
Hi. So we had a really interesting and lively debate on our 4 tables, and we were talking about retaining people in the workplace with RMDs and return of work after sick leave. And our 4 questions, I'm going to do the first 2, and my co-chair Brenda is going to take the second 2. So our first question was, what are the main challenges and barriers for people with RMDs to stay at work or return to work? And our first point was that appointments at the doctors and health professional offices and units are difficult to combine with working hours. With an RMD, you frequently have to go for blood monitoring, frequent hospital visits, and so on. And this can be quite challenging and can lead to further issues with your employer because you're having to take extra time off. So one of the things that our table discussing this question talked about was potentially health professionals providing out-of-hours clinics as a solution. And the 2 rheumatologists on the table seemed to feel that this was a feasible idea, maybe not hugely late hours, but maybe early clinics, early in the morning from, say, 7 o'clock, and maybe later in the evening till maybe 8 or 9 o'clock in the evening. I know in the UK they're trying to provide these sorts of facilities, and I think it's quite challenging in some health systems, but this is certainly something that could help. The other thing that I think could be a potential solution to this kind of thing is providing extra days for people in the workplace who have RMDs that don't impact on annual leave or statutory sick pay policies, so that you get a certain allowance, if you like, of extra days that you could use to accommodate these kind of appointments. Coping with symptoms of pain and fatigue take a lot of energy for individuals to manage. And that, of course, can lead to presenteeism. It's the sort of first stage. And this is why we need health professionals to really focus on keeping people well, and for people themselves to know when they need help, if they're experiencing too much pain, not to just put up with it, but to actually go and seek help. And why self-management is so important, because if you are a good self-manager, then you will be able to look after yourself better when you're experiencing symptoms than someone who doesn't have good self-management skills. So my view certainly is that we should be keeping self-management as important a thing as the clinical management pathway, and certainly something that we're focusing on in the UK. Number 3, invisible illness leading to lack of comprehension. We talked about that this morning a little bit. That's really a problem with some forms of RMD, where the person might look completely well, and that leads to colleagues not really understanding, not really being very accommodating or helpful in the workplace. And again, this leads back to the need for training of staff, training of HR departments. Number 4, not always possible to adapt the job. Some jobs are highly physically demanding, more so than others, and some jobs you can actually, you know, if you're doing an office-based job, you can transfer from one office-based activity to another. If you're a bricklayer or a construction worker, it's much harder to do that. And for some employers, it's going to be easier to offer retraining opportunities than others. Most of the employers are, in most countries, are small to medium-sized enterprises, and it's much more challenging, I think, for them to offer these kinds of retraining possibilities. So the second question was, what changes to working conditions are required in order to facilitate people with RMDs to stay at work or return to work? And here the first point that we talked about was the combination of support that's needed for carers as well as workers. It's important to remember that carers have sometimes just as challenging difficulties in the workplace if they are responsible for looking after somebody who needs a lot of help and support. And that support can be economical, it needs to be flexible, it might include things like looking at transport and changing arrangements for somebody to help them to get into work more easily. Things that could be done are, you know, more imaginative, are things like providing IT support for workers at home. So maybe providing them with a broadband connection, a laptop or something, so that they could work at home for maybe 1 or 2 days a week. So on particularly bad days, they can do that without it impacting as heavily on their workload. Flexible working hours, maybe starting a bit later. Often people with RMDs suffer from fatigue in the early morning, and having that opportunity to start a bit later in the morning, maybe work a bit later to compensate, is something that could be really helpful. Then we talked about support for mobility of workers from one country to another. I'm not sure I should be talking about that from the UK, but hey. But this is, again, something that I think is going to be quite challenging because we know that health systems across Europe are very different, and you know, different legislation is in place, different benefits apply in different countries. And so if you're moving from, you know, one country to another where these are very different, then I think that is going to be quite challenging, but something that maybe the EU legislation policymakers should look at. We talked about number 3 a little bit in the plenary this morning, reserving a percentage or quota of jobs for people with a disability. How can governments support private as well as public enterprises? Again, I think this is actually quite challenging, especially again for the small to medium-sized enterprises. How do you actually say, well, we're going to keep 10% of our jobs for disabled people, because if disabled people don't come along when you're recruiting, then what do you do? So I think that this is ideally it's a great idea, but how does it actually get implemented? And then lastly, multidisciplinary approaches recommended for adapting workplaces. We all, as different groups, patient organizations, health professionals, architects, psychologists, ergonomists and so on, we all tend to work in our own departments, our own areas, and we need to integrate more when we're talking about how we support people in the workplace. And there was a suggestion that maybe patient organizations could help here and maybe act as a facilitator, act as trying to bring these different disparate groups together for the benefit of looking at these issues in the workplace. And then for the next question, I'm going to hand over to Brenda.
Thank you. Question 3 we put to the hard-working members of our workshop. What should policymakers do to facilitate people with RMDs to stay at work or return to work? There was a discussion about having a better definition and categorization of diseases rather than having people with disability lumped into one broad category without proper differentiation between the diseases. Something that would be maybe challenging for the EU level is to promote more person or tailored approaches, to encourage employers to have tailored approaches to these solutions for workers in the workplace. There was a recognition that many actors are involved in actually successfully returning people to work, and a call for better collaboration between healthcare services, social care, employment services, a more coherent and integrated approach. And also a general point of the data gap, the lack of good data, the requirement for more research, and the constant and continuous exchange of good practice. At the level of member state and regions, the focus was on labour-related legislation, labour legislation that would govern such things as flexible working hours and teleworking, which would be an enormous support to those who wish to return to work and stay returned to work. Could we examine financial incentives or even other incentives for hiring and keeping people who have returned to work back at work? The member states, it was felt, could do a lot more in educating colleagues. There needs to be a collegial approach to the integration of people into the working environment once they're back. And in general, for all workers, and not just for those with chronic diseases, but for all workers, there should be a greater emphasis on workplace health promotion and promoting healthy work environments for all of us, and not just for one group. The final question we asked our now near exhausted workshoppers were, what should employers and other stakeholders do to facilitate people with RMDs to stay at work or return to work? And for the employers, there was a very strong call for employers to actually understand and comprehend what is available. There was a discussion about, in some member states, activities and programs that are available but under-exploited, under-advertised, under-publicized. And therefore the onus is on employers to understand what it is already available. And there should be proper training of HR staff to make sure that they too are absolutely up to date with what is available to someone or to groups of workers wishing to return to work, including an awareness of what it is constitutes discrimination, and to make sure that their activities are looking at how they can promote anti-discrimination in the workplace. The big thing employers can do, it's been said here plenty of times already today, is to show in a supportive environment a flexibility regarding the possibilities, regarding working hours, working practices. There should be better recording of the real reasons for sick leave. And employers have a lot that they can give in the creation of a genuine, overall supportive environment in the workplace. we also wondered about what incentives and employers could be given, including recognition or awards for those employers who really go out on a limb to foster and nourish return to work practices and keeping people at work. The other stakeholders we talked about, obviously patient organisations. There was a deep feeling that they can provide a lot of help and information. They can provide peer support. They can provide information to employers and also to workers. Many of them have confidential helplines. Health professionals are invaluable when it comes to liaising with employers and overall for fostering a positive attitude to returning to work and remaining at work, that working can have a positive influence in our lives. There was the Carol Black story, which was repeated by not only one but a number of people. Dame Carol Black is no stranger to this organisation. She has certainly attended past meetings of EULAR. She is a well-known activist in this area in the United Kingdom. She herself is a distinguished rheumatologist, and on many occasions in public she has said that she berated herself, or she regularly questions herself and complains to herself about the fact that all her working years as a rheumatologist, she never once asked a patient the question, what would you need in order to return to work? And I think there what she was trying to do was to illuminate the way we think in our own silos, and we don't look at the bigger picture when necessary. Finally, there was a discussion about the role of trade unions in raising awareness about these issues and advocating for these issues, with a recognition, of course, that in some countries trade union presence is much stronger than in others. And indeed, there was also the related issue an issue that is often one left of the trade unions, but one that is very vital, and that is the possibility for continuing to contribute and indeed to receive your pension when you do suffer from RMDs. And so thank you to all our very hardworking members of our workshop and to the support provided by the Secretariat. Thank you.
So thank you very much, Brenda and Elsa. And if there are no, okay, one comment. Yes, please.
Thank you. Looking through your slides, thanks for the feedback. As I represented trade unions, for us it's interesting that you didn't say that here the labor legislation is a framework for collective agreements, and all what is flexible hours, teleworking, is an issue for workplace agreements and collective agreements. And we have discussions on care leaves. You need to care for a sick child, for a sick or long-term disabled relative. So these are typically the issues that we would deal with, at least in countries where there is a functional sectoral social dialogue. And what I already said yesterday in the pre-meeting, these issues here, they would need to be broken down into some sectoral issues, because then the social partners can take them up, and then you can develop models that are appropriate for a construction sector, for metal workers, for health, for education, that look into sectoral models for flexible hours, for adaptation of work organization. And that's what has been said, a colleague before, that is typically the collective level of intervention, looking at the work organization, the work arrangement. So that should also come with the trade unions and with the employers, what you put behind labor-related legislation. That is our core task. So I'm astonished that you are not hinting to this. Thank you.
Okay, so I'm sorry, Maurizio, we'll have to move on. So please leave it for the panel discussion, and so because we need to go a little bit behind our time. So it's a pleasure now. First of all, I would like to thank all the workshop organizers and moderators for an excellent work, and you for having contributed so nicely. And so this gives me the pleasure to introduce to you Kathy Smith. She's our moderator, and she will lead the panel discussion, and she will also introduce the members of the panel. Kathy, the stage is yours.
Thank you very much indeed, and good afternoon, everybody. So I know you're all exhausted from the panel, from the workshops, but we need lots of energy for this panel discussion. The question we're asking is, do we need better EU legislation to reduce the burden of RMDs in the workplace? So this is the chance, as the Commission is looking over the legislation, is reviewing the legislation, this is your point of view. So let me, coming to the stage now anyway, but Heinz Becker from the European Parliament. You're there. Hello. Good afternoon to you, sir. See, I've now got to work out who's who as you take your places. So, and I know here we have William Coburn, who is the head of the Prevention and Research Unit at the European Agency of Safety and Health at Work in Bilbao. So you're a long way from home. We're all rushing onto stage. Just at the far right of the stage here, we have Bear Oomen, who is from the European Specialist Nurse Organization. Esther Lynch. It's very easy to work out which one you are. Esther Lynch, who is the Confederal Secretary of the European Trade Union Confederation. Next to Esther, we have Professor Tony Wolff, who is the Chair of the Global Alliance of Musculoskeletal Health and also the Chair of the Arthritis and Musculoskeletal Alliance in the UK. I know a lot of you know him already. And staying with us, Antonio Camarota from DG Employment and Social Affairs at the European Commission. I will stand. Thank you. Well, it's great that you're still with us after all day. So and you took part in the workshops as well. So you've really been sort of listening, and we're all waiting with bated breath to hear your views now later on in the day. I'm going to stand because it's good to stand. I was feeling actually that we ought to perhaps have sort of health and safety at conferences and do some stretching to get everybody energized. So the question is, do we need better EU legislation to reduce the burden? I wonder whether I could start with you, Heinz Becker, because we had one of your colleagues from the European Parliament this morning, Roberta Metsola, and she said that public health and social affairs are not very fashionable in Brussels, but the EU cannot ignore RMDs. Now, I think you're a spokesperson for older people in Europe, for seniors. What's your view on this? Should the Commission be doing more when it reviews its legislation, or is it adequate? What should happen in your view?
Thank you very much, first of all, for having received this invitation to place my impressions on this topic. So, let's see.
I think it should be on, actually, if you just talk into it.
Now it works perfect. Okay. Thank you very much. My colleague, Mrs. Metsola, is fully right, so I may leave, because that is not very fashionable. But as you know, all aging matters are not fashionable. People are really pressing down everything which has to deal with getting older in any terms, in wrinkles as well as in fashion, as well as in political terms. So we are fighting against this ignorance by the society. On the other hand, we experience a high level of attention on many aspects of getting older, especially by the ones who are approaching this age group. So let's say 40 plus. Because there happens two quite decisive events. One is that on labor markets, you are realizing that you are judged to get too old for whatever. Primarily women do not experience an adequate training on their job. They are already kept to be not worth to get the company's education programs up to getting the qualification for higher career jobs, etc. This is one aspect. Also men do, but women really in a overproportional extent. And the second is that you yourself individually know that you have to think of retirement, of pension, of whatever, and maybe you feel already some small biting devils in you which show you are not 25. So this happens at this age, and then we can experience that all magazines are full of tips for healthy aging, for better nutrition, for moving, but as you know, and by his own experiences, the pictures and the stories are quite unrealistic. People do not look like Mr. Clooney. Not so many, anyway, in that age. So they look different. But anyway, okay, let's say that's advertising. This is PR business, it's perfect. But it neglects, again, the real problems of the later ages. And these problems, of course, must be judged politically. And speaking about EU terms, not to be the priority legislative competence of the EU. We must know it is a national competence in the highest extent. So, what EU Commission does is admirable since years. They use all possibilities to influence legislation, of course in work time questions, frameworks, whatever, but the core discussion has to be led in the national countries.
So when this review of the legislation happens then, I mean, we're hearing a lot about refit, the whole idea of cutting red tape and simplification. We haven't heard yet from Esther Lynch what we will in a moment, but you know, clearly people are nervous about this review of legislation because they feel that it's going to be watered down. Now, from the parliamentary, I mean, you are the watchdog, if you like, at the Parliament. Do you feel that this legislation is fit for purpose the way it is? It should just stay the same as it is, or how do you think it should change?
No, it will change. If it changes, then not to the worse. I'm very sure, because the parliamentarians and the groups, the political groups, through all, besides some strange extremists, they all are aware and they have a consciousness on at least their own future. Believe me, you think of your own future too, and you know you have a clear obligation against this target group, which is, by the way, and I'm threatening sometimes with this aspect, which is by far the biggest group of voters at elections. So we are now trying to get the awareness that elder people who become older, who are older, belong to the top groups to be successful at any election.
Now, of course, it's not just older people that are affected. And Esther Lynch, I wonder whether I could bring you in on this, because you know it's very much people who are still very much working age as well. What's your view from the union's point of view?
Well, I wouldn't be in relation to legislative developments. I think that it needs organisations such as EULAR and trade unions to speak up more clearly about the need for better, more reliable rights. During the discussions on Brexit, I met with lots of workers in the UK. Very often what they said to me, I say to them, are you not worried about the consequences of Brexit for your rights? I mean, after all, health and safety, employment rights, but in particular health and safety rights, have their basis in EU rights. And very often what they said to me was, Esther, look, I can see that you get those rights, but I don't get them. And what they described to me was workplaces where they couldn't get a drink of water. They weren't allowed to have water at their desk even though they were speaking all day on the phone. They had to ask permission to go to the toilet. They had physical searches. They had 4 or 5 pace determinants. So that even the type of thing where you might, just want to take a breather, to step back because of the stressful work environment, that they couldn't even do that. And I think really that's the way in which the legislation is failing. I think it works for some people, but not everybody.
But are you talking about national legislation or European legislation? Because
the beauty of EU legislation in this field is it sets out the idea that as Europeans we will compete on lots of things except the health and safety of workers. And we say there's a threshold of decency below which no employer should go in Europe. And that threshold means that nobody should leave the workplace iller or in more pain than when they arrived there. And really that's what the directives are supposed to do, is to set out a strong threshold of decency that makes sure that those decent employers who are doing the right thing aren't disadvantaged by those, frankly, unscrupulous employers who do anything to make a profit. And do anything means including putting the health and safety of their workers at risk. I would just like to make one further point where I think the legislation could do a lot more. Is I regularly meet workers who want to get back to work, and indeed the employers want to help them get back to work. But they're regularly faced with rigid systems of social security that say you're either sick or you're well. That you can't have a situation where you might be well on one day, ill on the next, well 1 week, ill on the next. That every time you have to move in and out, you have to reapply, you have to make the application. And that really, I think, we should be able to look at better regulation on that, so that you encourage member states to put in place supportive systems that allow the social security system to be much more flexible and to allow for return to work agreements between the worker and the employer to be properly supportive.
And
5 seconds. Social security systems are the ones, you are very right with your examples, are the ones which belong only to the national legislation. So please distinguish always what we can handle on European level, as the title says.
Can I just...
If I can just actually reply to that. You see, this is what is regularly said. But I was telling you, coming from Ireland, I can tell you that the EU Commission and the IMF and the ECB had a big hand in what our social security systems could and couldn't do. So there's a lot that can be done. It's not acceptable for Europe to say, it's nothing to do with us, it's only up to member states.
Can I just ask in general, Esther, though, this idea of refit and analysing legislation and streamlining, if you like, are you nervous about that? Do you welcome it? What's your thought on this particular bit of legislation?
So we're quite afraid of the refit. The reason we're afraid of refit is because it's introducing inappropriate ways to evaluate health and safety legislation. So it puts far too much emphasis on cost-benefit analysis. And of course the cost-benefit analysis is normally the cost to the employer, not the cost to the worker.
Okay.
And so for us, our point of view is that the treaties are very clear. It's supposed to be about the promotion of health and safety in the workplace. It's not about some kind of balance sheet in which we add up. After all, how much would you be willing to pay not to be sick at work?
Thank you. Tony Wolff, obviously you sat through one of the workshops where we were looking at talking about legislation, and we've had the feedback from the workshop, and the suggestion is that everyone feels that a basic bed of legislation is important, but not too much because it's going to take away people's responsibility. What's your thought on that?
Well, I think we have to look at what are the areas where legislation could be used, or what other levers could be used from policymakers and others to make the changes happen that we want to happen. And I think for achieving our goal of preventing work loss and improving retention work, there's three areas we have to deal with. One is health protection, which we've discussed, but also health promotion, encouraging people to lead healthier lives, more physical activity, better diets, and also health care, making sure they get appropriate early intervention. And how do we actually achieve those? And then we have three players. We have the policymakers, the employers, and the employees. I think the key standard we have to have is good health and safety. I mean, that's a requirement across the board, and clearly legislation does have a role there. But we've heard the big challenges around implementation of it, rather than just having the legislation and make sure it really is delivering what we want. But we have seen from the statistics at the beginning that health and safety alone does not bring down the numbers. We still have lots of people getting back pain despite all the lifting regulations. So we have to look beyond that. And that's where we have to see what employers can do in general to be promoting health in their workplaces, having more adaptive environments to enable people to keep working if they have a musculoskeletal problem. We talk about work-related musculoskeletal conditions, but probably most people come to work with their musculoskeletal problem, and then it interferes with their work, and work may make it worse. So how to actually really enable those people to work? I'm not sure where legislation can come in there. There are some rules at the national level around flexibility, reasonable adaptations. Clearly, a lot of the ask we get from people with these problems is some flexibility in their hours, so some sort of flexible benefit systems are needed. But I think, as we've heard, that's probably at the national level. And then we come down to what employees can do. And they need to have, again, a responsive health and social care system, which is about enabling them to get back into work and not compensating them and keeping them out of work. And we don't want these barriers where you have to be labelled as disabled before you get any help, because that actually creates more of an irreversible situation. So I think we need to overcome that. And I think when it comes down to it, what policymakers can do is very much setting standards of best practice. So in the UK, we're creating a charter for what a good employer is, working with Public Health England as a way of trying to benchmark that standard and try and encourage people to try and achieve it. And drive things forward, naming and shaming, rewarding best practice, because I think it can't all be done by legislation. We've got to change the culture.
And do you think that sort of role can also happen at European level then, that sort of the compiling of best standards, exchange of best practices?
I think we do need to get better data. I think one thing I found when looking at the data that is not particularly good around musculoskeletal problems and how problem-solving people are, because we've also got to help people help themselves and encourage self-management and things like that, we've heard also.
Okay, thank you. William Coburn, can I bring you in now from the Agency for Safety and Health at Work in Bilbao? Tell us, how do you see this, the review of the legislation? Where do you see the gaps? What do you think needs to change?
Well, from the agency's point of view, we have a strong role in trying to provide an evidence base, a reliable evidence base for the policy making. And to that end, we carried out a survey of 50,000 workplaces across Europe, asking those responsible for managing health and safety at work everything about what they did day to day in workplace health and safety management, what were their main drivers and barriers. And we heard this morning about the importance of drivers and barriers. And legislation is important. It's the #1 motivator for taking action. It was cited above all, avoidance of fines, compliance with the legislation. It's the first concern. But it's not enough. And of course we looked on the other side, what were the major obstacles? And the first one is a lack of awareness. We don't have any risks. We're an office. Why would we have any risks? We're not going to have any accidents here. And the second is, well, we know the risks and we don't actually need to do anything. They're all under control. And the research shows that there are risks there. They're maybe not considering risks that lead to musculoskeletal disorders or risks that lead to psychosocial outcomes such as stress or burnout. But it's not enough on its own. So we need to raise awareness. That's the first step. So employers and those responsible for health and safety at work in the workplace are aware of their obligations and also aware of what they can do. And there we come to the importance of also providing support structures. And we can see by comparing the situations across different member states in Europe, and that's maybe one of the advantages of being in Europe, is that we're able to compare situations, and if you like, each one's a little test lab. We can see that there are examples of good support systems for workplaces, and often it's access to competent expert services that are lacking. To give you an example that's relevant for musculoskeletal disorders, in Finland, 80% of enterprises have used the services of somebody to help in the workplace design or design of equipment and workplaces. In other member states, it's below 10%. Ergonomists are just not on the radar.
But could something like that be built into legislation?
Well, I think proper support services, proper occupational health and safety services, proper surveillance, there are requirements there already. It's a matter of getting them actually implemented and getting compliance at the workplace. And just to finish on legislation, we did try and explore a little bit about to what extent the burden of the legislation is an obstacle. And there, interestingly, we were able to highlight the relevance or the importance of national legislation, because we're talking a lot about the burden of European legislation. But we had a situation where, I think it was in Italy, 80% of the respondents said that the complexity of the legal obligations are a significant burden. In other member states, it was below 15%. So really, they're all under the same European legislation. How has that been transposed into national legislation? What are the support structures and what's available to enterprises in practice?
Right, and that's interesting. So Barack Woman, you're coming at this from a very different perspective, of course. You're a specialist nurse, so you're not dealing with legislation, you're dealing with people. But what's your view? I mean, do you still think that legislation has a place, or is it really that it needs to be practice on the ground?
Yes, I'll speak from the very, very far end, so you have more legislation on here. But the legislation, let's be very clear, is the backbone. So we also can refer to this, as also I heard yesterday of Ergonomics, he said, well, when it's recognized by the disease by the World Health Organization, then it's legitimate to put it just to put it on the agenda. So legislation is very important. But for the very other end of the spectrum, it's how to reduce the burden of the R&D to the workplace. So as the nursing perspective, the nurse talk. So just cut me off when I'm going too long. From us as nurses, well, we see, but then I also reflect a bit on the issues brought up today. That you see, well, people get an illness or vulnerability. They go to the doctor, they diagnose them. They got an extremely long loop before they go back. And our interests as healthcare professionals, with also healthcare, to shorten that loop and bring it as close as possible. And bring the professional more as a manager in it, so you do not get overwhelmed by a lot of professionals, by a lot of rules, but get a manager. But first of all, it's patient focused. So we follow the patient journey. So this is very important to us. And as I speak of nurses, well, we have about maybe 3 to 5 million nurses in Europe. It's a vast. So we do not like to talk about nursing a bit the same as teachers. Well, you got a lot of teachers, but when you are a teacher, the first question is, on what subject? What grade? What school? So that's, I also like to invite people, if you're addressing nursing, what specialty? Not you often not, you're only doing that as a specialist, but when you specialty. And that's also bridging the issue to this field. We are European Specialist Nurses Organization, an overarching organization from diabetes, oncology, operating 17 organization, and the EULAR with rheumatologists.
So if we're talking about exchange of best practice, for instance, a best practice could be access to a specialist nurse like you at an early stage, bringing you into, as you say, shortening the loop And so this could be amongst the sort of the standards that seem to be the gold standard, if you
Yes, some nations are very effective, and I look at our colleagues, the nurse specialists in the EULAR are doing remarkable. So there's a lot of good examples. I'm not a rheumatologist specialist myself, so specific questions can be better addressed to these nurses. But there's a great field to work on.
Okay, thank you very much indeed. So Antonio from the Commission, we've made you wait a long time, sorry. you talked this morning about subsidiarity and proportionality and the whole refit element. Does that mean that really, I mean, tell us really how you see this legislation ending up. Do you think that will it be in any way watered down, or will it just be brought up to date so that the screen, looking at screen legislation is into the 21st century?
Thank you for this question. Thank you for this question, because it allows me to make it clear what exactly behind this quite mysterious acronym REFIT is. REFIT is the effort by the Commission to assess how fit legislation, not only in the area of OSH, is against the background of changing worlds of work. Technological changes, changes in the organization of work, globalization, and so on. So, with that in mind, it's clear that we need to see how still updated are some provisions, and in general, how effective the legislation is.
But what's your first thought on that, though? I mean, what do you think needs to change?
Yes. First of all, I must say that we are still waiting for the final results. They should be available by the end of the year, and after that, we will be able to give a clear say on that.
You must have some of an idea.
I would like to say that in terms of analysis and assessment of the existing legislation, and I'm sorry to contradict your statement before, we are not really only considering cost and benefits. The idea was to analyze the existing legislation against a very, very complex structure of indicators, which imply also relevance of the legislation, coherence, effectiveness. So, in the final result will take into account all these aspects, not only costs and benefits. We are completely aware that legislation cannot be measured only in terms of costs.
But I mean, some elements in the past in this legislative field have been dropped because employers did not want to see them. So you are obviously having to balance the whole business element with
this is another important point. And I think the Commission, and our Commissioner in particular, has been very clear on that on several occasions. This exercise is not intended to reduce or downgrade the protection.
Okay.
In any case, absolutely not. It's intended to make sure that legislation can be improved where appropriate, or we can also, in some cases, having as a result the fact that things are quite good. But I would like to say one thing. Legislation is only one part of the picture. Please don't ask legislation to do the job on its own,
no.
Because it's not possible. In order for the legislation to be effective, a number of other factors need to be in place. Some remarks during our discussion this afternoon were very indicative of this. There are, based on the same European legislation, countries that are showing excellent results, and others that are not so good score. Why? where is the difference? One difference may be to the way legislation has been translated into national laws. This is a possibility. A second possibility is the national OSH system. That means how different actors in the field, different structures are working. And this is really the very most important thing. And then legislation is coming closer to reality, because then it is translated into initiatives, policy, programs, strategies, culture of employers and employees. And this makes a difference. So legislation, and what we are doing now is to examine that, to assess that, is just one element of the picture. You have to consider the whole picture.
Okay, well, so the way that it's transposed into national law it can be a problem, and implementation is a problem quite clearly. I mean, Tony, how can that be improved? Certainly the implementation and
in the UK, we're doing a project working with employers and employees and other stakeholders in this, and I think it's giving some clarity to what can be done, how they can help people, because in general they are unaware. They know the regulations of health and safety and everything, but actually simple things like getting people to take mini breaks, doing some physical activity, how to adapt the workplace, how to be more flexible in their work. And so what we're doing in the UK with Public Health England is developing a toolkit for employers, which will actually give them some practical guidance, not going into very specifics of ergonomics or different tasks, but more general things about how to offer a more flexible, adaptive workplace to enable people to stay and work.
But how
and then
responsive
recognising, I think they are positive, but then there'll be some carrots rather than sticks, with sort of recognition of them doing it, giving them a sort of charter standard of what they're delivering, and showing them as exemplars, and that does seem to help. But there is always perceived to be a cost, and the big issue is around SMEs, where they don't have those resources, they don't have the in-house people to do it, and how do you actually help them and encourage them? I think there'll have to be some nurturing. I think that's where we as a community can be helpful, because we're not employers, we're not employees, we're not the legislation, we're helping people. So I think we as a community, R&D community, have an opportunity to help, and getting patient champions and people like that who can explain how it's helped. One concept we have is also training middle managers, but using people with the experience of R&Ds to do the training alongside occupational health professionals to really get the message across that given the chance you can work.
I'm talking about awareness raising. Neil was telling me earlier that Robbie Williams has just announced today that he has arthritis and can't dance anymore. But I mean, you need to have famous people like that, don't you, to sort of, really get the word out there. Esther, you wanted to come in?
Yes, very briefly. You could imagine bringing forward the right to effective enforcement, both of, say, employment rights, but also health and safety rights. And what would the right to effective enforcement look like? Well, what you'd be talking about there would be sufficient labour inspection in line with the International Labour Organization principle of having a certain number of inspectors per 100,000 or 10,000 in the workforce. It could also be protecting people who do speak up in the workplace, so protecting people who blow the whistle, but also people who come forward in the workplace and say everybody who works on the cash account, on the cash desk, has a pain in their right shoulder when they go home. Because very often, certainly if you're on a 0-hour contract and you're the person who comes forward and says everybody leaves with a pain in their right shoulder, probably because the seats are too high or too low. Or indeed, how many of us shop everywhere we go and see that people stand all day? There's almost no seats now, you see. So it's all around us. We see it. People say there's enough law. But then maybe what we need to do a lot more about is to protect the people so that they feel empowered to come forward, not afraid of the consequences. And certainly the most effective way to make sure people are protected is to make sure that you have trade union-led health and safety reps in the workplace. There's a mountain of research proving that, a mountain that says trade union-led health and safety reps keep workers safer in the workplace. And yet there's still a reluctance to put in place measures that will provide workers with the right to trade union representation on health and safety matters.
Tony, you wanted to come in? I mean, we talked in the workshops about incentivization for employers, so a different approach for them to be sure to.
So again, with what we're doing in the UK is actually trying to help employers understand the problems they've got in their workforces, because a lot of them aren't fully aware of that. So I think helping do surveys which really bring out those problems and challenges, because for example, we've done it in office-based jobs, and people surprisingly are not aware that office-based people who hot desk are actually doing light manual work, carting their computers and papers around and sitting in variable chairs which haven't been set for them. So it's really highlighting who is at risk, so they recognise they've got a problem, convert that to money, and then come in with some suggested solutions of how they can be a better employer.
William, do you have any views on this whole business of implementation?
Yes, I was going to highlight as well what Esther mentioned about the importance of effective worker participation. That's an obligation under the European legislation that's been implemented in different ways across Europe. In some cases, there's a threshold of 10 workers or more. You must have an elected worker representative on health and safety at work. Over a certain threshold, you have to have a health and safety committee. And as Esther points out, there's a wealth of evidence from the research showing that where there is a formal representation structure in place, your health and safety outcomes are notably better. So that's one way where legislation is having an indirect impact on the success of wider-OSH legislation.
Mr. Becker, do you see that, within the European Parliament, for instance, is the Parliament itself a good employer? Do you have health and safety requirements?
Yeah, more space to breathe, but we are quite satisfied, frankly speaking. It's okay for us and for our staff, and not only for the MEPs, but also for our assistants. We live in the same rooms, so the conditions are the same.
It was suggested earlier that when we were talking about possible incentives for employers, that there could be some sort of, almost like a star system for employers, to say, this is a star of excellence because you provide all the proper conditions for your employees. A little bit like the flag system for beaches, the blue flags, you could have a similar thing for employers. Could that work, and can you imagine that?
I can imagine everything what belongs to a European principle I would like to be implemented, obligatory. And this is bench learning as an obligatory principle of all European 28 or 27 governments. To be obliged to study the best practice, to be obliged and to draw consequences out of it. So if one country, in that case it's mine with a small group of people in the state...
You're from Austria.
Austria, yeah. In the state health insurance system, offers a yearly visit at your doctor, signing an agreement to improve your health conditions, stated by the doctor, it's the blood pressure, it's whatever, and after a year, there is a bonus if you reach it. Of course, there is no malus, but a bonus, so incentive. Such examples and best practices must be studied and thought over, or others. There are hundreds. So this is what I think is what also Commission is intending, and you may understand that parliamentarians do not praise Commission too often. But in the field...
That's why I put you at separates.
Yes,
keep you apart.
It's quite good. We don't get in... Yeah. But in fields where, as you also had described, all of you, that legislation is not all. The soft power of the EU means emotional approaches, means best practice models, means bench learning, and of course means to install other principles, such as lifetime healthy aging. We must start aging from childhood onwards. And there are a lot of prevention mechanics. It's nothing else than prevention. But from the childhood on, to learn it in school. Then social partners take over during the professional career. Senior organizations and others take over in the pension ages. Because there is a great potential of saving money for the social systems, and at the same time to improve living quality. And to have your individual objective in mind, the early detection can only be realized by prevention from early ages on. So this is what I'm happy if a commission goes along that way, because you are on that route. And there are some aspects also to say, I do not hear too much that the key working group for musculoskeletal disorders, such as attendants, delivery truck drivers, freight handlers, laborers, nursing aides, etc. There are key groups who suffer. So I didn't hear anything about focusing on them, first of all. Just focusing. And then I'm very sure that we can put pressure on the governments. And this is the only way it will work. Good concepts on European level. Parliament is always on that line. We, of course, also refuse a lot of proposals by employers, but we also refuse proposals by the employees' representatives, because they are as well not adequate, or, in many cases, do not match the legal subsidiarity of the national member states. So it's a clear reason why we have to reject. But we are on the line of the Commission, and I think lifetime healthy aging as well as benchmarking should be implemented.
Bear, let me bring you in on this idea of lifetime healthy aging. I mean, you obviously that's the sort of thing that you work for and you care about.
Lifetime, in many aspects. We see, well, nursing. The majority of nursing aging is also aging. I think the average age is not 20, not 30, not 40, even above. So that's a fact. The other thing is, as I'm representing nursing and also addressing the point you're doing, be more specific in who are those who suffer from back pains, and our profession, especially the healthcare assistants, it's very hard for them to work on them in the stations for a lifetime, because sometimes they really have to fall back because of these situations. But what I try to do is more. I'll make some remarks today, but the top word is now leadership, and also appealing to the issue that Hans brought up today. It's just be responsible. Take responsible. So if you look at the far end on the legislation, on the other end, so it's your daily practice. See good practice and just take us. In some nations there are no rheumatologists, nurses. In other nations they do. But if they're not, then as to the rheumatologist, grab a nurse and say, you're going to be my assistant. That's what I learned in my leadership. And my mentor said, okay, Barry, you're going to teach leadership. Who are the persons around you? I said, well, no. So this is the first thing you have to do, get a lot of people around you in this circle.
Okay, thank you. Did you want to come in, William? And then please, can we put the microphone here, please? Yes, William.
I just wanted to point out that the European Parliament, in fact, has been very forward-looking and prescient. And I was this morning reporting back to the Employment Committee of the Parliament on a 3-year large-scale project that the agency took forward, delegated by the Commission, but that came from a decision of the Parliament looking into the health and safety at work of older workers, and we translated that into a project on healthier and safer at all ages, and that has, under the objectives set by the Parliament, the aim of collecting practices at policy level and at workplace level and in between on successfully taking a lifelong approach. And it highlights many interesting practices across Europe, including highlighting, I would say, especially at policy level, the importance of coordinating across different areas, different policy areas. It's ones that these have an effect then on the individual cases of the workplace, but it's that cross-ministry, cross-policy working that's essential. And we've got good examples such as a pooled budget, for instance, in Sweden, a central ministry in Finland coordinating various ministries, platforms for collaboration such as the INQUA program in Germany, and they're all well documented.
Can you just give us an example then how that cross-sectoral, cross-policy would work? I mean, give me what sort of decision might you take? And
I mean, an individual's decision about whether to return to work is not only conditioned about whether they actually feel fit. It's also conditioned about what sort of adaptations they can expect in the workplace, how that might impact on their rights to a disability pension, what compensation they might have, a whole host of rights. There's also discrimination issues that may come into play, and they all are normally the competence of different ministries, different budgets, different competencies, and they all have to come together. One of the areas that we identified was actually having primary care practitioners consider a return to work as a positive health outcome in itself, and we see examples of that.
Right.
To work program in Austria, for instance.
Thank you. Yes, sorry. Do you have the microphone? Yeah. Please put your hand up if you'd like to join.
I got very important suggestion in the last workshop
Where are you from?
conclusion. I'm where from? Maurizio Cutolo, Italy, past president of EULAR. So I got very important issues. And one of the most important issues, I think, is related to the education of the doctors, GP. Because the patient you have at workplace is the same patient that take the bus, the same patient that go to the market, has the same problems. So in the workplace, he transfer that good education, the bad education that has achieved during his progression of the disease. So what is important at this point? Nothing to invent for the authority. The society, like EULAR, produce guideline, recommendation, how to manage a patient, how to follow the patient, how to administer the drugs, how to choose the drugs. So there are guidelines. And it's easy to propose the link to such disease. And here, so single disease, to follow and to respect. Because it's obvious that, for example, we need, as was proposed, a better definition, categorization of the disease. We have, in the rheumatic disease, at least 200 different conditions. And for each one, there are recommendations and updated suggestions. And these are validated, and so maybe the basis for the legislation, because it's something validated, nothing to invent. And secondary, it's very important and not too much done to educate the patient to manage the drugs. Because the patient keeps the drug, for example, in summer close to the window, or the temperature is 30 degrees, and in a few hours, the drug becomes all dangerous or do not work anymore. Or the patient, they don't know when to take the drug after dinner, to find the foods and when. So there are a lot of problems that they have all the day, and they transport in the workplace. So before to say you have in the workplace great problem, we have to link to the guideline and recommendation already validated and the result of a lot of inputs and experience, and link this when you have a problem. And second, the education starts when the patient has started to be healed. There is a primary education to prevent the disease, and secondary prevention to manage and to adapt the life everywhere, and the general practitioner is very important this way. And this is my opinion. Thank you.
Thank you. Does anyone want to come in on that? Tony, do you want to?
I think,
Whoa!
just going on the focus of the general practitioner, I think it's very risk assessment. Going back to the focus on the GP, I think it's very important that the first person someone encounters when they have a RMD that's affecting their ability to work has a focus on getting them back to work, and does so early, because we know that early intervention is effective. It doesn't necessarily have to be a general practitioner. Many people will respond to physiotherapy or other therapists as well, but the sooner we get people back into work, the better. And a lot of these conditions are potentially chronic, but you can actually make them not chronic if you get in early enough and reverse them. I think that's an important issue.
Do you think, Antonio, from the Commission's point of view, that apart from the legislation, there is more that could be done in terms of the exchange of best practice and on a more formal footing?
Definitely. Is exactly what I was trying to say in my present intervention. I think that legislation is I like very much the word backstone. It is a backstone. Yeah. When it comes to prevent and to make sure that provisions are implemented by employers and by national authorities. But on the other side, we need much more to make sure that the preventative culture is really operational in the member states. And one of these things is, of course, better information, awareness raising, and of course, exchange of good practice. I think that there is lots of space, of room for maneuver for the European Union in this area, where we can improve, better coordinate the way best practices are circulating in Europe. There are a number of important experiences already ongoing. European Agency on Safety and Health at Work is an excellent example. We have other European bodies who are working in this direction. For instance, the Tripartite Advisory Committee on Safety and Health at Work. We have the Senior Labour Inspectors Committee. And these are fora, spaces for discussion where the interface between European level of OSH governance and national level is occurring.
Okay. Heinz Becker, you want to come briefly, then Tony, and then Esther. And if anyone else has got any...
Only shortly, for all of you to understand the mechanism. Commission's statement is very elegant and very polite. In fact, Commission also suffers of less communication budget to create awareness of what happens where. How can I have access to which best practice? There are not all these platforms in the internet with full service services to be used for everybody and also for the professional groups in the member state countries. Because member states demand year by year more to be done by the European Commission on all fields, but cut the budgets every year down. So this is one aspect. One should never forget that we are in a situation that there are excellent concepts, excellent programs, but many people have no idea about that.
But I presume the agency could help from, William, in...
Yeah, indeed, we do, and there'll be an excellent online platform to showcase the different practices that we've collected, and that'll be launched by the end of the week. And our publications are already available on our website for free download. But I would echo Mr. Becker's point that there is a constant call from the member states to do more with less.
Okay, thank you, Tony.
I think this is where there's an opportunity for civil society and NGOs like EULAR to help out and work with. We undertook recently the UMUS project with support of the EU to create a surveillance and information system focusing around clinical standards of care and outcomes, and that does include work as one of the outcomes, and that could be expanded and used as a way of disseminating information and trying to drive up standards of care.
Esther?
Yeah, one of the ways you could do this for real is that under public procurement rules, you could allow member states to have a tender process which would privilege those companies that have in place workplace committees, that have in place measures that help the worker get back to work, that provide reasonable accommodation, and you could make sure that those companies that don't have in place worker committees that don't support the workers get back to work are actually, you know, that they face a disadvantage when applying for public tenders.
That's an interesting approach. I mean, what do you think about that, Antonio?
About this?
About yes.
Yes, this is a very interesting approach, but we are again at the same level of discussion. This is something that needs to be done and must be done and can be done at national level. What is the role of the European Union there, of the Commission? It's the role of facilitator, coordinator. But we need to be realistic. There are things, for instance, enforcement, that are not the competence of the European Union.
Yeah.
And where we have some powers in terms of conditions which are ensured by the treaty regarding the possibility of adopting legislation in this area to promote initiatives, but for a number of other things, probably today the most important things, implementation, enforcement, translation of general goal-oriented provision into actions. It's about the member states to operate.
You wanted to come back, Esther?
Just because it's absolutely the competence of the Commission to ensure that member states are properly implementing public procurement rules, and indeed the Commission issues numerous guidance on how they can do that, including on how to ensure that social clauses within public procurement are properly in place. So I think it would be fantastic if the Commission could support the proposal that those companies that have in place effective health and safety and go further and properly support workers to remain in work actually have a better chance of getting and winning tenders rather than it being on the basis of lowest cost.
Hans Becker.
Just to give my comment, I agree fully that this is a topic of really even priority, and you will experience that also Parliament will take up this idea, but make it clear. It's national competence, so unions should better start at the national governments to put their pressure on them and not shifting to the EU competence. It is not. And that's why EU, Commission and Parliament will absolutely foster and absolutely support. But all the work has to be done by your governments in all of your countries. And this is what we have to understand, that the EU very seldom is failing, but the government of the member states, they are failing in migration as well as in social Europe.
Can I just ask, do we have any more questions? I mean, where do people in the room think there are gaps in the legislation at EU level? Is it the national governments that are the ones responsible? Is the European legislation okay? I mean, the workshop seemed to suggest that it was okay, but then, of course, not everybody really knew the detail in the legislation. Do you have any thoughts, Neil? Just put you on the spot here. Do we have a microphone? Please.
Thank you. I think there's a sort of consensus, I think, that needs building about what good practice and what reasonable looks like. Certainly some of the disability legislation, for example, in the UK, has some pretty good consensus about what constitutes reasonable practice. And it's that sort of approach, I think, that is needed. I think in terms of the sort of legislation we need, I find it quite interesting that there have been opposite views expressed today by people who are all experts. So on the one hand, very prescriptive and detailed legislation, as I think, William, you said, can in some circumstances be helpful because it spells out quite explicitly what could and should be done. But then, and again, if I'm using your words, William, but I think you gave an example of a hoist. So if the regulation says you must employ utilise a hoist to help someone who has physical mobility problems. Okay, that's very clear, but it's no good unless people know how to use it safely and effectively. So you can only see the legislation as part of a raft of measures which have to include education, training, and work around awareness and attitudinal change. So that's not easy, and that suggests the only solution really is to be found out of a sort of multidisciplinary approach. I see a lot of things coming out of progressive models of healthcare, the multidisciplinary team, the partnership approach between the healthcare professional and the patient, where you move away from sort of one entity telling the other entity what it is you have to do, towards actually drawing up a kind of contract and working together towards some shared objectives. And that's why we need the employers and the trade unions and the healthcare professionals, and most importantly of all, the individual people, to agree what it is that has to be done and working out the best ways to get there.
Mm-hmm. Any other thoughts? I wonder whether... oh, sorry, yes.
No, I just wanted to mention one other aspect in which the Commission, I think, is making a difference, but not through legislative initiatives directly, and that's through providing leadership for national strategies on health and safety at work. We're supporting the Commission in the analysis of the national strategies, which have all responded to the leadership and the example provided by the European Strategic Framework on Health and Safety at Work. And there we see a common now taking note of the importance of the aging of the working population, all highlighting demographic change as a priority, lifelong preventive approach, the importance of including social partner involvement in the development of the national strategy. I'm not saying that we see perfect examples in all cases, but at least now it's obvious, and we can see a shift and a progressive move in that direction.
Okay, thank you. Just as we come to a close, I wanted to ask you all a kind of magic wand type question, in the sense that in 30 seconds, and I really mean 30 seconds, the most important thing that policymakers must get right for the future management of RMDs in the workplace. I'll go to the actual policymakers last, and so I'll ask Tony first of all. I mean, what you know, if there was one real thing that's got to get right, what would be the priority?
I don't know how a policymaker can achieve this, but what is really needed is that flexible workplace which responds to the needs of the employee to enable them to stay in work, be open about their problems, and come up with a way of making sure the job and their abilities match to enable them to continue. And it's how you actually can use legislation, policies, sharing best practices to actually achieve that and get it rewarded, and get employers to recognize that investing in employees' health is of economic benefit to them as an employer.
Okay, thank you. Esther?
Yeah, absolutely. Actually put the worker first. You know, stop saying we put the worker first, and stop saying we put the worker at the centre, but actually do it. And then just finally to make the pitch again for the EU Commission to issue guidance that public procurement rules can be used to privilege those companies who are doing it right.
I would say help get the message across to all workplaces, but also to those workers who are not in normal standard forms of work. We've mentioned the difficulty of reaching small and micro enterprises, but we also have new forms of work arising, and those are particularly vulnerable workers. So I think you really need to get the message across to those and make sure that there are support and guidance structures that cover them also.
Okay.
I think it's invest in the health workforce, and also following the paper on the United Nations Commission on Health and Employment of Economic Growth releases this report. Invest in your staff and educate and see standards and quality.
Thank you. So Heinz Becker, then, as a policymaker, where do you see the priority being?
I have a dream.
I've heard that before, somewhere.
To make health and security at work a strong part of the European semester. To make it sanctionable against member states who do not do their job. And include social partners as the ones who are the best to produce quality as we wish. There are many member states who even neglect social partnerships. So that's my dream.
Thank you. That's it. And Antonio, sorry, you haven't got the microphone. Sorry.
It's not true at all that we are not sharing views. Most of the time we are. And I think just linking to what you have just said regarding to negotiate European semester, I don't know exactly whether this is a realistic, for the moment at least, political goal. But one thing that we need in the future, I think, is start looking at the health and safety as a systematic area of competences. An area where our different actors are operating and different structures are operating. And when if we want to really improve things, we need to consider the system as such, not isolated elements such as legislation or workers' participation. No, the system is something that is putting together different competences, and to improve, really, you need to improve the whole system. This is something we need to probably to develop in the future. First of all, in terms of what we know about it, because for the moment we are very, in my view, imprecise picture of how things are from this point of view. I think that this makes really the difference between member states where things are very good, even excellent, member states that are, let's say, less brilliant in implementing OSH provisions.
Okay, well, thank you very much indeed. Thank you all very much indeed for your input. I'm very, very glad, Tony, that you survived the whole thing. Thank you. Thank you.
Great to meet you. Thank you very much. Bye-bye. All the best. Bye-bye. Spotty guy.
So thank you very much, Kathy, and the panelists. I think it was a very, very highly informative panel discussion. And now we're going to the final contributions, to the final speeches. I just learned that one of the speakers, Member of Parliament Takis Haji Georgiou, is still being interviewed for a video, so he will join us later. And I would like to call upon Ricardo Baptista Leite to the podium. He is a member of the Portuguese Parliament, a public health advocate, and interestingly, he's a medical doctor himself and head of public health at the Institute of Health Sciences of the Católica University of Portugal. And thank you very much for coming here and giving the one of the concluding speeches. Thank you.
No, thank you. It's a true pleasure and an honor to be here to close this session. So I thank EULAR, first of all, and to thank your Brussels office for arranging my travel here. I saw that next year it's going to be your 70th anniversary. So I'll be expecting an invitation to a party, I guess. Congratulations, a great work over decades.
Already tell the executive director to note down your
yes, please.
They don't have to travel far.
A parliamentarian never misses a good party. You know?
Right.
I'd also like to acknowledge the presence of Elsa Mateus, the president of the Portuguese League of Rheumatism, with whom I have the pleasure to work with back home. It's great to see that you are here. And the truth is that I had already registered to be at this meeting before I was invited to be a speaker. And the reason I had done so was because I truly believe in the importance of the theme of rheumatic and musculoskeletal diseases, from a public policy and public health perspective, of course, to get up to date on recommendations and policies, new policies happening at the European and national levels, and also due to my firm belief about occupational and health safety and the role it will need to play, how it will need to be more impactful in terms of public health. The role of occupational and safety and health are tremendous, and we have not exploited that role as we should over the years. First of all, we heard in the debate and from the working groups that we need to invest in self-management and self-care. But that implies that people are minimally literate when it comes to health. And the truth is, health literacy normally stops around your schooling ages, maybe university, for those who get to go that far. When you get into the work field, it stops. And if you look at how our employment population is, our employed population in Europe is getting older, those that are over 50 never had any formal health education when it comes to health literacy. So I believe, actually, that occupational health could play that role. Secondly, occupational health should play a role in preventing diseases and promoting healthy lifestyles. Just this week we had Mental Health Day, the role that occupational health could and should play in this field. And what we heard today, the importance of early and timely diagnosis of diseases such as RMDs, so that treatment can be made available as soon as possible, and thus leading to better prognosis. But lastly, the reason why I believe that occupational health and safety should play an active role is due to this huge transformation that we're assisting in the whole health sector field. We are evolving towards what has been called value-based healthcare. This will lead to the fact that we will be financing health systems and those that work within the health ecosystem, not based on administrative procedures, but based on health outcomes. Clearly, there is a role for financial initiatives to help occupational health services to push for these health outcomes also in the workplace environment. So being a bit of a bookworm myself, I was reading the literature before coming, and because I come from infectious diseases, so I'm not a rheumatologist myself. But I came across a really interesting paper written by our colleague Julie Edgar that was published on WebMD. And she decided to publish a story of one of her patients that I'd like to share with you. So it goes like this. Nancy Hardin, age 71, from Tennessee, US, was diagnosed with rheumatoid arthritis 11 years ago. A few months after her diagnosis, she quit her teaching job at a local high school because she could barely walk. Then she started taking a biological drug and became nearly symptom-free. Nevertheless, she decided that going back to the classroom would wear her out. She did, though, become a volunteer translator for local Spanish-speaking immigrants. So we can suppose that she's not voting for Trump. And a member of the Tennessee Council of Development Disabilities. And quoting this patient, she said, "To tell you the truth, I work almost as much as I did when I was teaching. My doctor thinks my disease is in remission." What this goes to show you, and to show us all, is that with appropriate treatment made available early on after diagnosis, along with other measures that we heard here today, people with RMDs can actually get their lives back, become a productive force within society. And yes, we know that 1 in every employee leave the workforce due to rheumatoid arthritis alone. However, this is half than what used to happen 20 years ago. We have evolved tremendously over these years. And yes, we have seen the social and economic impacts. It's always good to remember the 120 million citizens in the EU that actually suffer from RMDs, a fourth of our population, and the economic burden, the 240 billion euros we're spending, 2% of our GDP on direct costs, 650 million euros a year on workdays lost alone. But the reason for us to act goes way beyond the mere economic factors. The right to work is a basic and fundamental right, as it was declared by the Universal Declaration of Human Rights. To work is a means of self-realization, through which each and every citizen can achieve fulfillment of one's own potential. These citizens, as we were reminded here this morning by the European Patients Forums, become more productive, less prone to discrimination and exclusion, they become healthier, they have a better quality of life, and lead happier lives. And after all, happiness should be a goal for all of us. As Dr. Rik Helen Moe this morning from Norway told us, there are actions that can prevent RMDs altogether, or at least lower its evolution and avoid severe disability. These include education, leading to healthier lives, and may I add, we should also create healthy environments so that could be possible. So if you want healthy diets, make sure you have healthy food available. Secondary prevention, avoiding early disability through physical activity and weight loss, and timely access to treatment to prevent, as she said, injury and to prevent the evolution of the disease before disability, before depression, and before leaving work. To these recommendations, I add those published by Lutman and his colleagues on strategies for the workplace environment that fall under 4 categories. Ergonomics, jobs should be designed to that most people can carry them out. Second, work performance strategies. Employers should adjust working hours, as we heard here in the debate, and shifts to the employee's capabilities. A moderate pace over a large period of time, or a longer period of time, is normally better than an intense pace over a short period of time. We know that. Workplace well-being programs that can go from exercise to cafeterias with healthy foods, from pre-work warm-ups to drinking water at the workplace. And lastly, workplace training, like physiotherapy education, for example, or cognitive behavioral return to work counseling programs for employees with short-term absences. We heard this morning from the Commission that the EU policy and legal framework on occupational safety and health covers most of these proposals and concerns. However, Marius showed us the results of the survey on RMDs in the workplace at the member state level. And the main overwhelming conclusion is that policies to prevent RMDs and disability at the workplace are not effective currently in the real-world setting. Something clearly needs to be done. It is clear that employees do not have fiscal or financial incentives to act on, and they are not sufficiently informed to understand the economic gains they'd achieve through preventing RMDs. But we currently heard today that these and other factors lead to discrimination, which drives fear of employees telling their employers that they have a rheumatic or muscular disease and that they need to work less, or that they need to work slower, or that they need to change their job function altogether. And of course, unemployment drives even further that fear of being fired. Just as an example, healthcare professionals as ourselves can actually play a negative role in this place. The Arthritis Research UK identified a problem with the need to remove the rheumatoid factor test from the diagnostic criteria because, as we know, seronegative arthropathies remain undiagnosed or underdiagnosed, leaving individuals with disability symptoms but no diagnostics. Even GPs, general practitioners, tend to consider that the disease is not present in the absence of the rheumatoid factor. So basically, the person is considered to not be sick despite the pain, despite the disability. And because of this, the person ends up losing their job, because if the doctor says they're not sick, why should the employer believe in them? And they lose all their disability benefits. So when doctors stop listening to what patients say, something is terribly wrong with the medical profession. To end, and in a nutshell, we need to reduce discrimination against people living with rheumatic and muscular diseases. Employers need to identify and manage adaptations and adjustments in the workplace. And we need to improve attendance and performance at work by promoting rheumatic and musculoskeletal diseases. That is what EULAR has been doing over the years, and I'm grateful to be part of that movement here today. I now have a lot of homework to take back to Portugal so that together with Elsa and with all of our colleagues back home, we can work towards making the lives of people with rheumatic and muscular diseases better. Thank you very much.
So thank you very much again, Dr. Leiter. So you will be certainly invited to the party, of course, provided that you take Ronaldo along with you, because obviously we're great fans of the Portuguese football team, and so all the best to the team as well. And thank you very much for coming. So now we change the order a little bit, and it's now a pleasure for me to introduce to you, I would say, an old friend and also a true supporter of EULAR. It is Takis Hajigorgiou, member of the European Parliament from Cyprus. He has been vice chair of the European Parliament Interest Group on RMD since it was established in 2009, and he has been really an invaluable supporter through all these years. And thank you very much again also for coming today, but also for your contribution last year. We had a very, very exciting workshop and World Arthritis Day subject last year, cross-border medicine. And thank you very much for coming again, and thank you very much for your speech.
Good evening, ladies and gentlemen. I know you are here during the day. I wasn't, but I think that I had many important things, very important things to do in the Parliament. Still, I will follow the discussions you had here today through any document I can have in my office. I would like, first of all, to thank you very much for attending this very important conference today on World Arthritis Day. As many present here will know, I have been speaking at EULAR's conferences in the past 2 years when we discuss the topic of access to healthcare and cross-border healthcare. As you know, this year's topic is on prevention of chronic diseases in the workplace and the retention of people with these diseases at work. This is a very important topic for the EU institutions and certainly also for members of the European Parliament. It is highly relevant to discuss this at the EU level, as unlike the provision of healthcare, the EU in fact has strong legislative powers in this area. Today's discussions have shown the extent of the issue of poor working conditions and their impact on workers and their families. As we all know, RMDs that result from poor working conditions can have a substantial and detrimental impact on workers and their families. These diseases are, however, also a burden on the productivity of our economies and the sustainability of our welfare states. The numbers alone are staggering. 1 in 4 citizens in Europe are affected by RMDs. This means that a total of 120 million people are estimated to suffer from these diseases in the EU alone. They are also the main occupational disease and therefore the main cause of work loss and early retirement. For me, this shows the urgency of the issue and the need for the European Commission to prioritize the presentation of legislative proposals on health and safety. This has already been delayed for over a year, and it is now time to take action and tackle these issues through new legislation. All the evidence that has presented today shows the clear need for better legislation and policies to reduce the still enormous burden of RMDs at work. Through better prevention and retention of people with RMDs, in my opinion, one aspect is important above all. New legislation and policies have to be focused on the needs of people with chronic diseases regardless of their occupation, age, or social status. As a result of the economic crisis and the modernization of the workplace, new non-traditional types of work are becoming more and more common. Precarious work, such as short-term contracts, agency work and self-employment often leave workers at risk of poor and unsafe working conditions. The European Commission has to take this into account and make sure that all workers in Europe are covered by new legislation and policies. Better prevention and retention could also have a positive effect on unemployment in Europe, as chronic diseases often cause unemployment or perpetuate it. Unemployment, especially among young people, is a major concern for us as policymakers. It is therefore crucial that we lift people out of unemployment through better reintegration measures. Adapting the workplace for people with RMDs and other chronic diseases is therefore important to make the labour market more inclusive. It is therefore crucial to ensure that new legislative proposals and the revision of the EU strategic framework for health and safety at work do not lower working conditions in order to cut red tape that is perceived as a burden on businesses. The opposite should happen. The European Commission should use this opportunity to strengthen and modernize working conditions for the benefit of workers, businesses, and economies as a whole. In all these debates that we have at the EU level, we should not forget that it is in companies where legislation and policies have to make a difference. There are still significant barriers for full and proper implementation at member states level, where working conditions often depend on a company's willingness and priorities. This is a worrying state of affairs, and it is therefore crucial that the European Commission makes sure that implementation of existing and new legislation is coherent and comprehensive. This also will require more working consultation and more inspections by labour inspectors in the member states. Another issue often mentioned in these debates is the ability of smaller companies to implement health and safety legislation. Many argue that small and medium-sized enterprises are unfairly burdened by health and safety legislation. However, if implemented in the right way, better health and safety legislation benefits smaller companies without imposing any unnecessary administrative and financial burden. After all, we should not forget that the impact of an employee on sick leave is felt a lot more in smaller companies than in big multinationals. I therefore call on employer organizations not to stand in the way of these urgently needed legislative improvements and ensure that their employees can benefit from the better working conditions they urgently need. To summarize, better working conditions for people with RMDs and other chronic diseases would without a doubt contribute to overall social and economic improvement. This is why I call on the European Commission to present legislative proposals and policies by the end of the year that substantially improve working conditions for people with RMDs and include quantitative and achievable targets. It has to be ensured that new legislation and policies improve preventions of RMDs and importantly also include the obligation to adapt the workplace for people with these diseases so that they can remain in employment. Last year, the European Parliament called for a comprehensive legal instrument against RMDs in the workplace, which shows our strong support for this crucial cause. I can assure you that my fellow members of the European Parliament and I support better health and safety legislation in Europe. I look forward to working with you again and again to make better working conditions a reality. Thank you very much.
So thank you very much, Mr. Georgiou. So thanks again for these remarks and the speech. And it's a particular pleasure, and last but not least, before we come to the final conclusion, to introduce to you Leen Meulenbergs, who was recently appointed the WHO representative to the European Union. EULAR had the pleasure to work with her in 2010, and by that time, EULAR co-organized the EU Presidency Conference on RMDs together with the Belgian EU Presidency, and that led also to the recognition by the EU that RMDs are indeed major diseases, and as we learned recently, also the WHO has recognized this as well, and so we couldn't thank the WHO more and all these involved, including Tony, that this is, of course, a major step forward for the patients who suffer from these diseases, because we are sure that more resources will go into these diseases to improve the patient's life. Thank you very much for coming.
Thank you, Chairman. Thank you for your nice words, and it's nice to be back here. I feel very welcomed. Thank you for inviting WHO to address the closing of this session. And I have I'm doing something which I'm not sure I'm allowed to do. I'm touching a screen. Going back to okay.
It's just
Safe, very safe. Thank you. Musculoskeletal conditions are the greatest cause of disability in the WHO European region. They affect all ages. They are a major cause of worklessness and in older ages loss of independency. Good musculoskeletal health is a prerequisite for mobility, economic independence, and active, healthy aging. It is an important contributor to the prevention of non-communicable disease, given the importance of physical activity. Musculoskeletal health is impaired by conditions such as arthritis, low back and neck pain, osteoporosis, and fragility factors, injuries due to occupations or sports. Risk factors for musculoskeletal health are similar to other non-communicable diseases, and musculoskeletal health can be promoted by their modification, in particularly increased physical activity, ideal body weight, smoking cessation, moderate use of alcohol, along with injury preventions. Control of these diseases and prevention of disability depends on availability and timely access to musculoskeletal health systems to enable early intervention and rehabilitation. Services need to be person-centered, integrated across the health community and oriented towards enabling people to self-manage their musculoskeletal conditions and toward reducing medicalization of common problems. Ladies and gentlemen, the words I just read to you are a direct quotation from the Action Plan for the Prevention and Control of Non-Communicable Diseases in the WHO European region, which was adopted very recently at the 66th WHO Regional Committee meeting held in Copenhagen in September this year. While these claims are not new to anyone attending this meeting, the language used is a departure from the standard language used in WHO documents on non-communicable diseases. And they are now claims welcomed by ministries of health of 53 member states in our region. Since the 2011 UN Political Declaration for the Prevention and Control of Non-Communicable Disease, there has been correctly a focus on 4 main killers: cardiovascular disease, diabetes, cancer, chronic respiratory disease. And there is ample justification for this at a global level, given the burden of disease and the fact that these 4 groups of diseases share the same common risk factors. In Europe, though, there is a similar ample justification for expanding the scope of action. The European Public Health Policy Framework, Health 2020, which was adopted in 2012, aims for a holistic understanding of health and well-being that extends beyond mortality into the prevention of disability and the optimization of function. The aging of the populations of the European member state is leading to an increasing burden of musculoskeletal diseases, which is already in itself the greatest cause of disability. And as recognized in this action plan, there is also the commonality of risk factors, such as population-based approaches for the prevention of non-communicable disease, and it can be seen as effective prevention for other chronic conditions. This commonality has been recognized in Europe for many years, and indeed was already referred to a decade ago in the adoption of the European Strategy for Prevention and Control of NCDs. It is now clearly enshrined in the current action plan that will guide our work for the next decade. Throughout these years, EULAR has been a strong ally, and not at least in the past year. Your contributions to the expert meetings held in August 2015 and in February this year were crucial in the development of this document and in our achieving an organic and more cosmetic synergy between non-communicable diseases and musculoskeletal conditions. So where do we go next? There are multiple possibilities available to us, and I just suggest a few. For example, maybe the time has come to devise a public health framework for addressing musculoskeletal conditions in health systems for varying levels of resource constraints or availability. WHO expands its work on NCDs in Russian-speaking countries in Europe. There is an opportunity to expand professional development and opportunities and technical support on musculoskeletal conditions in these countries as well, and we hope that EULAR can be there with us as well. The work of EULAR in these areas and our collaboration in the past year is a good basis for fruitful and equally productive future. So we are looking forward for a very strong collaboration. And I hope, Chairman, that this will lead to an invitation for your birthday party next year. Thank you very much.
So thank you very much, and of course we'll put you on the list as well in Madrid. So thanks a lot for these encouraging words. And now within the next hour or so, no, just kidding, just briefly, I would like to show to you some conclusions of our conference we had today. Let's have a look at the, okay, F5. Okay. And all right, so the final remarks, and let's go on. So, and of course, this is a very ad hoc and swift presentation that we prepared, also after the workshops, and of course, this is not the final document, But I think these are some very important items that we need to discuss and work on. So obviously, primary, secondary, and tertiary preventions are very important. And we stressed quite a bit that we need to, and by the way, I guess we can make all these slides available to all of you upon request. They will be on the website of EULAR, so in case you need them for your subsequent work. Obviously, it is very important to raise awareness about RMDs in the workplace. Many people, and I just would just like to give you the example of the taxi driver. And I frequently discuss a few things with the taxi driver when I go back home from the airport. It's usually either football or medical aspects. And then they said, "What are you doing?" And I said, "I'm a rheumatologist." And they said, "What? What is this? What kind of diseases do you care for?" And so and sometimes people are not aware that these are very, very important diseases, that they constitute a huge burden. And of course, this is also true at the workplace. Everyone knows what a stroke is, a myocardial infarction, or of course cancer. But RMDs are frequently not known. This is very important. So also we need to reinforce legislation against exposure to risk factors. We talked about, let's say, bricklayers, but also nurses who carry huge weights, but also workplaces where you stare at the screen all day long, and that needs to be done as well. We need to, and this is very, very important, to promote and also learn from good practices at workplaces that are working very well. And we learned this this morning. There are very good examples, for instance, in the Scandinavian countries where they took all this to heart, and these are very good examples. And as I mentioned, we want to take out all the positive things from this conference. So we don't want to complain that much. We want to learn what is actually working. And so this is, of course, very important, like training, warm-up exercises, and others. And I have one example with me. You know this fitness tracker, which I send to my wife because I get a weekly a report of all my fitness tracking and all the steps, and I send it to my wife because she's controlling me, what I'm doing, and to make her happy. And I don't cheat it. I don't give it to any other young persons. It's really on my body, and that is something which we can already take as an example, so that we motivate each other to work more, to walk up around more at the workplace, of course. A crucial thing, and you are aware that we are initiating the Don't Delay, Connect Today campaign from EULAR, obviously is early stage detection and treatment of RMDs. Everyone knows it is crucial to treat a myocardial infarction immediately, a stroke immediately, but the public thinks, well, it may take a couple of weeks or months until you can see a patient because it's not a deadly disease and so on, which frequently is not true at all. And also the RMDs need immediate attention in many, many instances. So again, we need to raise awareness of this need. Also, culture of empowerment is very important. So we must empower the patient, that the patient also knows what is best for the patient, what to do, and to contribute actually to early detection. Facilitate access to timely and high-quality physical and psychological treatments for workers who are suffering from RMDs. This is very important. It's not just medication that we need and that we have, very good ones actually, but it's also physical therapy and psychological treatments, for instance, in the case of low back pain and others. Include work in assessing cost effectiveness of health policies and interventions is very important. So because ultimately an employer will ask, okay, I have all these nuisances that I have to change the workplace, I have to buy new chairs and desks and so on, but is this really necessary? Does this result in more money for my small medium enterprise? And we need to tackle this, and this is of course very important. Retention of people with RMDs in the workplace and facilitation of return to work. This is of course extremely important, because we know that these are gifted, highly motivated and committed workers who don't want to stay at home because they are too lazy to work. No, because they are disabled, they have the disease, but nevertheless, we can treat it quite well nowadays. And so we need to implement new ways in order to return to work as quickly as possible. And that, of course, would also promote flexible, adequate working conditions, and so better equipment and other items that will help these patients. And again, promote good practices that focus on capacity after after having been incapacitated because of an RMD. Again, I would like to stress we need to generate evidence of return on investment, generating healthier workplaces. There we need data, we need trials and studies, which frequently are quite expensive. They're not just very, very cheap. They need to take into account, this is actually it's an own science to do that. So this will be very important to convince all the stakeholders. Comprehensive and coordinated approaches against RMDs is very important. So we need to foster the coordination between policies, employment, health, care and public health, social affairs, and I must say I learned a lot today from the contributions of the trade unions. So they are truly the partners here in identifying the needs of the patients and to put up some pressure, which is necessary, and implement coherent strategies against RMDs. So finally, implementation of the knowledge of healthy workplaces into everyday practice is important. So the legislation alone doesn't help, it needs to be implemented. So the legislation needs to be adapted. So I learned today that probably we don't need that many new laws, but we need to apply the laws and fill the gap to changes in work patterns and organizations. So guidelines are very important that are given by the EU for the implementation of this legislation. One way we learned a lot about this is also positive motivation. So we don't want to put up penalties, but I think it's much more helpful to generate incentives such as tax deductions for generating healthier workplaces. And since I guess Germany is we are paying the highest taxes in all of Europe, so I think only Belgium is worse than Germany. So that would of course be something that would be very helpful to the employers as well. Just in the recent speeches, we learned a lot about education and training. This is of course very important. Health literacy is one buzzword here, and EULAR has taken this to heart because we have founded the EULAR School of Rheumatology, where also the patients have their own classroom and will generate the own material. Everyone realizes that this can only be done well by the patients because we need to find the language of the patients. Together with the physicians, then we will have hopefully material that can educate and train those involved. And finally, we have to overcome silo approaches. So saying that one stakeholder say, well, this is not my business. No, let's go to this committee. No, that is another commission maybe. So that would not be helpful. So we all need to work together in order to reach the best outcome for our patients with RMDs. And with these words, I would like to thank you all for having spent the entire day, in which I think was a highly informative workshop. I enjoyed it personally a lot. I would like to thank all the speakers and the panelists and all those involved in the organization for having contributed with marvelous speeches, lectures, and remarks. And of course, I would like to also thank the people behind the scenes well, he's not behind, he's sitting there. It's Neil Betteridge. Again, I introduce you as a mastermind behind it, and it's of course it is Sören Haaf, Federico Torres, and Birte. You're standing here, and I think Maria and others from the EULAR office have done a magnificent job. Did I forget anything? Anyone, Birte? Because you tend to forget always the most important people. And Macarena, of course. So Macarena, thank you very much. So Macarena arranged the excellent weather we had yesterday for the videos that you will be able to see, and we would like to thank the technical staff as well for having done a marvelous job. And so again, thank you very much. And I think we, as some sort of a reward, it's not a major reward, but some sort of reward, I think we have now a cocktail, and so we can do some additional networking now. And thank you all very much for coming. Thank you.